Everybody, and welcome to the simulation workshop. Before we start, I'll just introduce the team that we have here to help you learn today. And our lead instructor is Dr. Ram Kumar. So would you like to introduce yourself?
Hello, I am Dr. Ram Kumar. I am a student of Diploma Particularly. 1985 I moved to Manipur, so it's kind of 40 years since I'm here in Manipur. And very fortunate that I moved from Bangalore, which is my original hometown, to Manipur, because currently Bangalore is second like it. I've been here for 40 years. I consider myself a Manipurite, okay? And also very happy to be in this center because this is a center that we started in 2008, and I was lucky to be made the director of that when we started it. So coming here brings back a lot of good memories, okay? And Tara, who's there, can I just ask her to come forward right now? So Tara was one of our anesthesia technicians, and when we started the center, the only demand I had from the management was, okay, I'll run the center provided you give me Tara to run the center. They agreed, and Tara has been there since then. Okay? So thank you, Tara, and along with her now Veena has joined, and Soumya wouldn't come today. So all of them will, that's our team, our support team from Simulation Center, and I've already introduced them. Only Soumya is missing. So I'll hand over the mic to Tara if you want to say anything. Or Veena? Okay. Manasa? Or you can introduce them?
No, I can do that. So that is,
Manasa,
that is Mr.
Rishant
Rishant is there, Manasa is here. This is a team from Ladal. Without them, we cannot be doing this workshop. And where's Dinesh? Dinesh is always hiding.
And before you change the slide,
Yeah,
Bala
and
Ganesh was the
Mr. Bala
person
Ganesh.
that helped us set up the center. Now I'm so happy that he's gone up the ladder, and he's totally in control of Ladal all over Southeast Asia, is it?
All over India.
All over India. So Tara is there, I'm there, and Bala Ganesh for you. We all were there from the start of the center.
And of course, Mr. Jagdish is here. He's there, right there. He's part of our AV team, and again, helping us to make this workshop useful for you. Right, and we have different scenarios that we have created. You have facilitators for each of these scenarios. So we have Dr. Ram Kumar, Dr. Anjana, and Dr. Priya on the airway team.
Hi, good afternoon everyone. I'm Dr. Priyanka. I'll be taking you through obstetrics scenario.
Along with Dr. Rajaram. Yes.
Yeah, he's just stepped out.
He's just stepped out, but he's around. We have Dr. Prithvi, our faculty from emergency medicine, who's going to take you through the trauma. Prithvi, you want to say anything?
I'm looking forward to working with the simulation with all of you. I'm the doctor, Aparna and Dr. Sushma.
And I'm Dr. Nisha. I'll be taking you through the pediatrics scenario along with that's Jessica, Dr. Jessica. All right, from the trauma scenario, especially last time, because it's not something I'm used to as a pediatric anesthetist. So I learned a lot. So we all will learn from each other and make it as interactive as possible. Some things that we stressed on during the previous rounds also, please be loud and clear, because that will help not only your teammates when you're doing the scenario, but also us as facilitators to help you move on to what you need to do next. 2, 3, 4. Okay, and then go on so we can split into teams.
3, 4, 5,
No, 1 again.
1, 2,
4,
2,
3, 4, 1,
3, 4,
1, 4,
1,
4, 1,
2.
That's it, right? So I'll call all the 2s forward. All the 2s forward.
While that's happening, is there anybody who's here who's not signed in the sign? Everybody signed, no? Okay.
Yeah, come forward. Come forward. So we are going to start with the pediatric simulation. I'll first ask you to introduce yourselves and what you're doing. Take the mic and speak into the mic. You're in hold it close.
Hello, good afternoon everyone. I'm Dr. Sumashri.
I'm second year resident from Kamini Medical College, Hyderabad.
I am Shweta. I am first year in KMC.
Loud and clear, Shweta. Okay.
My name is Shweta. I am first year in KMC Manipal.
My name is Pranati. I'm a second year resident from KMC Manipal.
Good afternoon, everyone. My name is Ravali. I'm second year PG from KMC Warangal.
Good afternoon, everybody. I'm Dr. Divya, second year PG from Panagar Medical College.
I'm Dr. Rajat from AJ, second year resident.
I'm Dr. Mamta. I'm a freelance anesthesiologist from UP.
Right. Thank you, everybody. So we will go through the scenario once. We'll do the pre-brief and what we expect you to do through this scenario. So the objectives are to identify a child in crisis, perform the steps necessary to manage the child in the simulated context, whatever it may be, and demonstrate the correct use of drugs, medications, doses and routes, and demonstrate good team dynamics because you have a team working with you through the scenario, right? And of course exhibit professionalism in your scenario as well. Please verbalize your actions because unless you verbalize it loud and clear, we won't be able to help you move on. Verbalize your anesthesia settings because we don't have a machine to simulate the settings. So if you want to keep a fresh gas flow, please say I'm going to keep so many liters of flow, or I'm switching on sevoflurane, or if you're putting on the ventilator, say I'm going to put on pressure control ventilation with this much pressure, inspiratory pressure, peak respiratory rate and so on. This mannequin, you will be able to hear sounds, you will be able to feel a brachial and a femoral pulse. You can auscultate and listen to breath sounds. You can look for capillary refill time. You can look at the pupils. You'll be able to observe cyanosis. You can intubate and place an LMA. You can apply suction. What you cannot do is, again, we don't have a simulator for a machine. So again, verbalize your settings and do not cause trauma to the mannequin. Okay? No poking the mannequin in any way. There is an IV patent in situ. Do not switch it on because it will cause a leak. Just simulate it and say it out. Okay? Right. So this is your patient. Your patient is a 1-year, 4-month-old child weighing 10 kilos, scheduled to undergo a right herniatomy. Is otherwise fit and well. Mom gives a history of runny nose and a dry cough for a day, about 5 days ago. No fever. He's active, playful, has a good appetite. He has an IV cannula in situ on his right upper limb, and this is patent. So you as a team have to come up with a plan for anesthesia and go ahead and anesthetize this child. So the team roles that we expect, we have 1, 2, 3, 4, 5, 6, 7 of you. So we can have 2 anesthetists at the head end. Who would like to be? We need 1 call for help. Ma'am, would you like to be the call for help? Yeah. So ma'am will be the call for help. So ma'am, we will ask you to go out in a bit, in a while. We need 2 on the head end. Who wants to be at the head end? You're all second years, right? Yeah. Maybe 2 of you can be at the head end. Go on. So essentially you're going to be the team leaders, right? Who's going to be with him? Go on. We're all learning from each other. It's okay. All right? Right. Okay. We need an anesthesia technician. Who's a technician? One of you? Jonathan? Go on. We need a mother. Who's a mom for the baby? Will you be the mother? Okay, go and be with your child. And I will. You can be the surgeon. Okay, and I will give you. You can be an assessor. You can see what is happening. Are they doing the events? So, as a team, do you want to know anything else before we go forward? As a team, excluding you. Is there anything you want to know from me before we start?
Previous history of any surgeries?
No previous history of surgeries.
Allergies?
No allergies, no.
No. Not on any regular medication.
Not on any regular medications. Anything else?
NPO status.
NPO status is adequate. The child has had water about 2.5 hours ago and some formula feed about 7 hours ago.
Not wheezing.
No, chest is clear. No history of asthma. Only cough cough for a day, mom says, with some runny nose. For a day, about 5 days ago. You have asked something, allergies?
Asthma history.
No asthma history. Anything else you want to know? If not, I'll ask ma'am to just step outside. We'll call you when if needed. So, are you ready as a team to start? You've talked among yourselves. So, the setting is the pre-anesthetic room. It is not yet the operation theatre. And this is your child. So you have a crying child in the pre-medication area. Mother is desperate. You have to be a very concerned mother. Okay? Your child is crying. You can cry as well. That's what we usually cry. Mother, child, both will be crying. Yeah. If you have your notepads, you can keep it with you. Otherwise, you can just keep a piece of paper, jot down notes. Please be loud and talk clearly and loudly. That has been told right from the beginning. Loudly. No whispering among yourselves. Otherwise, I'll make a be loud and clear. Otherwise, you will not be able to move forward. Loud here.
Okay, evaluating you at the end of it.
Since we have the IV line secure, let us pre-medicate the child.
10 kg child. How much are you giving?
1 mg. 1 mg per kg. Slowly. 5 mg I'll give. Midas.
Loudly, we can't hear how much you're giving, what you're giving.
Glycopyrrolate 0.01 mg per kg, so 0.1 mg of glycol.
10 kg. 0.1 mg.
Then let's go with midazolam. Midazolam also 0.1 mg per kg.
So are you all making the plan or are you somebody giving it? I don't see anybody giving anything. Drugs are in the tray. Mother is very unhappy. You're all standing around the child and talking about it. Mother saying, doctor, why aren't you doing anything? My child has been fasting.
We'll shift. I want to operate. I have 10 cases.
The surgeon has come.
Shall we start? I'll take your belly inside. Do something.
Like what?
Yes. How much should I give?
0.1 mg.
I'll give 1 ml of this.
1 mg.
We have to dilute 0.2 to
0.5, we can give 1 mg.
I'm giving 1 mg. I've given 1 ml of
glycopyrrolate.
Give 1 ml of
Of
midazolam.
midazolam.
giving 1 ml of midazolam.
Push the line. Flush.
So you're giving ketamine and midazolam.
No, only midazolam. Glycol and midazolam.
Midazolam, how much? We can't hear what you're saying.
Glycopyrrolate 0.1 mg
Yeah.
and midazolam 1 mg.
I'll give 0.1. You want me to give 1 more ml? Okay. stopped crying. I think we can
Yeah,
take
we
the
can
child
shoot the
inside.
child.
Yes.
Yeah, we can.
Okay, now you've come into the OT. You've come into the OT. Mother can come out.
Okay, I have a phone. Size 2, they want me to.
Surgeon is very impatient. See, why have you brought my child, my patient in and you're not...
I've scrubbed.
Yeah, see, surgeon is very impatient. You've brought the child in, you have not done anything to the child.
Shall I start? It is silent.
Is the child okay? The surgeon is asking.
I'm painting.
No, ma'am. We need water.
There is silence.
Mask ventilating the baby. So the auto flow. Connect the monitors. Pulse oximeter.
Use the ambu bag, please. It's right there in front of you.
You verbalize when you're connecting
Yes.
this monitor. Okay, just verbalize.
I have connected the file with the ECG. Pulse oximeter has been connected. NIBP is also connected. O2 is connected
Yeah,
on
you
flow and
verbalize.
ventilate the patient. Switch on the CO at dial setting 1. Suction is ready?
Yes.
Yes. Yes.
Size 1.
Yeah.
Surgeon says, what is happening here? I see some abnormal numbers on the screen. Wow, what are you doing with my patient? See, you can't do all this. Where's your this thing? If this is the way you're anesthetizing the patient, I want another anesthetist.
I'm waiting.
Yes, ma'am, we have to connect to O2 now.
The saturation is not improving.
The baby okay? Yes, sir.
Seems there is like complex and crepitations are there, course crepitations and spasm.
He's hearing things.
Can you do with propofol and this?
I will do something about it. I want my baby to be fine before I start the surgery.
We
In the hospital.
Saturation picked up. I'll start. Started crying now.
give some propofol. 4 ml of it.
Giving 4 ml of propofol.
Yeah.
So surgeon wants to know if he can start the surgery. What is happening? You get propofol.
Child is awake. Just now. Now can I start?
No, ma'am, wait.
1 hour. 10 cases are there.
Propofol given.
Able to maintain.
Yeah.
Able to maintain.
Yeah.
Chest raise is there.
Yeah.
You can give muscle.
Muscle relaxant, cyst attractive.
How much?
1 mg. 2 mg. 2 mg of cyst.
1 Jesus attractive given.
Given.
Timer is on.
Okay, 3-4 minutes are over.
Inflating. Okay, surgery is fine. Shall I start? Shall I start?
I can't hear the R&D.
Deep breath. There is someone waiting outside. You want to call them?
I need help. Call.
Call whom actually? Call whom?
A senior anesthetist.
You deep breathing? Loudly, even I can't hear.
You have to be loud. Come and stand here and talk to her. Come and stand here, doctor, and talk to her.
Yes, yes.
We have induced with propofol and cysticeracurium. We tried intubation and we couldn't do it.
As a 1-year-old child, mom 10 kg.
What was the problem with intubation?
R&D wouldn't come.
Yes, ma'am. Graduation is at 18 ma'am currently.
Can you give me some suggestions?
Saturation is 68 ma'am.
When? 12, 11? What else have you given?
Chest raise is there, huh? Chest raise is there.
Paralyzed.
Should I start or wait?
Heart rate is also dropping. Have you given anything?
We have used cysticeracurium.
Okay, now about half an hour is over. Since you're,
Mom 77.
since you've started.
Yeah, you better take the program.
Giving approval. 0.3 mg.
Half an hour is
Given
over
a
since
flush.
you started the induction and intubation.
The limit? 12, 11. size? Cuff. Cuff inflated.
See my idea somewhere and see if it is there. Oh, what is that with the tummy? Sure, it is all okay.
Extended.
Sure, it is so big. Tummy is bloated.
Well, that is not working.
Hey, I'm testing here. Okay. Oh, sound is coming. See. Much better.
Deflate the
Deflate
leg. What do you do next? Alright.
What's the child woke up? Huh? What's the child is crying?
Yeah, child is crying. So
Stomach is so much distended. Child is like grunting.
we put a rice tube and then we give.
I can see some chest raise now, but the tummy is very big. Very big.
Cry is better. The chest is moving now.
But I think
Will do some
tummy, I'm not
suction.
happy with tummy. This tummy I can't tolerate.
Rice tube, suction.
Nice.
Oh, so much of gas has come out. Sha. You see, half the, I think this tummy, okay, now it's much better. Let me know when can I get start. Actually, we can understand.
Pardon?
Right, I think we'll stop the scenario here.
Not working?
Stop the scenarios here. I want you, can you all take your seats, please? Thank you, good effort. So how was the scenario? Use your mind, tell us what you felt, what you went through, what you thought went well. I'm sure something would have gone well as well.
The initial history card.
Okay.
Later on. We were late to call the senior.
Okay, let's come to that in a bit, but what else went well? Do we want the entire team here? There's one more person, right? Put up a check. What else went well? All of you can also contribute. What went well? Vinay, you have something to say?
No one panicked.
Very true. Nobody panicked. Nobody was in a visible flap at least. Maybe inside you were all in a flap, I don't know. But nobody was in a visible flap. Yes? Any other good points?
Baby survived.
Baby survived. Baby didn't die. Yes. Yeah. What else? Yeah, but mom was sent out. Yeah. But mother was very calm in spite of a crying baby. Yes. Otherwise, usually you will find the mother in tears more than the baby. Yeah. Then? Right. Shall we just go through what happened in this scenario? So you had a crying baby with visibly normal airway. There were no problems with the airway that you could elicit from history or from the examination that I told you about. What happened next? In the pre-medication area, you decided to induce. What is the dose of drug that you wanted to induce? I heard some ketamine, I heard some midazolam, but you guys weren't loud enough. So we had to keep asking you, what did you finally give? Midazolam. How much midazolam?
0.1 mg per kg.
0.1 mg per kg, okay. 0.1 mg per kg. 1 milligram.
1 milligram.
You think that is all right for a 10 kg baby? Yeah, it's a bit on the higher side. For this child, I would probably go only about 0.05 or so at the most. No, 0.05. 0.05. Okay, so 0.5, yeah, 0.5 milligrams, yes. I heard some dose of ketamine being bandied about. What was the dose of ketamine you wanted to give? 1 mg per kg is a sedative dose or an anesthetic dose? That's an anesthetic dose. What is the sedative dose of ketamine? 0.5 is the maximum. It's 0.2 to 0.5 milligram per kg. So if you're going to be sedating a child, especially in the pre-medication area where you don't have monitors, then you want to go on a bit on the lower side, especially if you're going to be combining it with another drug. Right. So you sedated the child and then you brought in. And then what happened? Yes. So we were waiting for you to ask for monitors. So the monitors came on a bit late, and the minute they actually came on, did you all, any of you notice what the saturation was? Because you had sedated the child and you had not really done anything to make sure oxygenation was okay. So the saturation was 68 or 70 or something, quite low on the lower side. So probably you could have thought of, think of what you would do in a normal scenario. Okay? So you should probably have asked for the monitor straight off, put it on and see what needed to be done. What next? What happened next? Who was the person who was observing you? What next? What happened next? Induction. How did you induce this child? Yes. That's perfect. Is there a contraindication for IV induction in this child? No, airway is normal. There's no problem with it. How much drug did you use?
2 mg per kg propofol.
Yes. Yes, and then what happened? No, that was later. Initially you gave one.
Initially 4 ml I asked for, and CO was on when she was pre-obstetrics.
So there was nobody telling me, we never heard the sevoflurane at all. That's why I told you, you have to be loud and clear. Did any of you hear the sevoflurane? Sitting there, some 1 or 2 here heard. We did not hear the sevoflurane at all. Okay? So that is why your child started crying again and waking up. And then you gave 40 mg of propofol after that.
No, only once we had.
You had given propofol twice.
Once.
That was much later, that's what I'm trying to tell you. It was much later that you gave the propofol once you induced. So how did you induce the child?
No, we induced with the 20.
No, you had given twice. Because the child, if you remember, started crying and waking up in between, and then you asked for a second dose of propofol. So that's what happened. We did not hear you say switch on the sevoflurane, whatever it is, and then you went on to paralyze the child, right? Then what happened? Were you able to intubate?
No, intubation.
What do you think happened at that point in time? Is laryngospasm possible in this scenario? You've given the muscle relaxant, so unlikely it is laryngospasm. Could have been esophageal intubation. How will you detect esophageal intubation? Absence of ETCO2. Is there anything more you want to add on to that? One by one. Okay. So things like expansion of the chest, looking for misting, is that very reliable? No, not at all. Is 5-point auscultation reliable? No. What is the only thing that is reliable? Can you quantify or qualify that a bit better? Sustained rise in ETCO2 above what level? We're talking in millimeters of centimeters what? So how much? Above what? Above? I heard. Why 10? Why are we saying 10? What are you trying to differentiate between cardiac arrest? Yes. So one of the qualities of high quality CPAP is to correlate. So sustained this rise in ETCO2, which is above 10 millimeters of mercury, at least 6 to 7 breaths you should have an ETCO2 trace, is the recent guidelines. And so you didn't find any of that. So probably it was an esophageal intubation. So then what did you do?
instrument called again bag ventilation. Called
Yeah, so you removed the tube and then you tried bag mask ventilation, right? So were you able to bag mask ventilate at that point? No. So what should you, if you can't bag mask ventilate at any point, what should you do? Change your position, yes, okay. Adjuncts you can use. Oral airway, did you use an oral airway? Okay, that's something that you could have done. Anything else? So why is that important? So you had a patient who's desaturating on table. What is the first thing you should do? 100% oxygen. So you need to check again whether you are providing that 100% oxygen. Yes, I know you are still in the process of inducing and intubating the child. But it's always a good idea to just verbalize and see, okay, is there any nitrous on? Because a lot of people have the habit of turning on nitrous for induction. So are we really on 100% oxygen? Check. It's a good idea to check, right? Because it's already a compromised child, right? 100% oxygen. Then, what else? Airway, oropharyngeal or nasopharyngeal airway. That's something that you could have tried. Then, suctioning out. You think there might be a secretion or something. Okay, yeah. Call for help is something that could have been, I think somebody pointed it out earlier as well. It could have happened a bit earlier. Okay. Then I prompted and said about half an hour, 45 minutes has gone by. And then what happened? Then you started, did any of you notice some kind of noise coming from the child? What was happening then? Probably the child had come out of the muscle relaxant, and then what was happening? You think laryngospasm. Why do you think laryngospasm? You think because the patient was out of neuromuscular blockade and
Inadequate depth of anesthesia.
Inadequate depth of anesthesia. Yes, so when you try to intubate, when you're doing an airway maneuver, please remember that those are the periods of time when you have a light plane of anesthesia. Okay, so if you think that might induce a laryngospasm, please give an extra dose of IV drug. Okay? If you do end up with laryngospasm, is more sevoflurane going to help you? No. Why? The glottis is already closed. You need to open or deepen the plane through an IV route, not an inhalational route. So that's what the child ended up having. So I think the team failed to recognize that it was a laryngospasm, but they did do something else to allow the mask ventilation. What else did they do? They did put in a supraglottic airway to facilitate ventilation. So they recognized that it was from. Did you all recognize that it could have been an esophageal intubation? You did. You pulled it out, and then I think when Matt came in for help, you tried a laryngeal mask airway, which is what you're supposed to do. Try and mask ventilate or ventilate the child at least. Right. Laryngospasm. How do we recognize laryngospasm? How can we recognize it?
There will be no bad. Paradoxical chest rise.
So is it no chest rise or chest rise with paradoxical movement and no back movement? Chest rise may be there, it will be there in fact, because laryngospasm, does it happen in a paralyzed patient? It never happens in a paralyzed patient, it will never happen in an intubated patient. Because the pathology is at what level? At the vocal cord. So it will never happen when you have a tube in place, it will never happen if your child is paralyzed. That's why I said 45 minutes, half an hour, 45 minutes are over. Okay, and then the child had that noisy breathing and some, problems happening, desaturation again. So the first one in your scenario was because of the esophageal intubation, and the next one was because of laryngospasm probably. Now, to recognize it, you will have chest movements. Will you have a patent upper airway? So how do you differentiate? So will your bag be moving? You've connected a face mask to the patient, right? Bag will not be moving. Will not be moving, and will the upper airway be patent or not? It should be patent. So otherwise, that's how you differentiate between an laryngospasm and an upper airway obstruction. So if your bag is not moving and your chest is rising up and down, or there is a paradoxical movement, it could be an upper airway obstruction, or it could be a laryngospasm. The way to differentiate that is ensuring that your upper airway is patent. How do you ensure that? We already discussed that. Use an oropharyngeal airway, use a nasopharyngeal airway, change your position, change your technique of mask holding. Ensure you have a tight fitting mask. Again, if your mask is not tight fitting, it will not conduct to the back. Right? So in the presence of a patent upper airway, if you have paradoxical chest rise in a spontaneously breathing patient, you will need to suspect laryngospasm. Yes? Any questions so far? Let's go on to, if you can just look around, you can come this side and so that's laryngospasm, sustained closure of the vocal cords resulting in a partial or complete obstruction of the airflow. So how do we recognize this? This is exactly what we've talked about so far. You can have a partial laryngospasm or a complete laryngospasm. And how do you differentiate? Partial, you may have some noisy breathing. So I think the team had a little difficulty in recognizing the noisy breathing. So we had Dr. Priyanka come and tell you there's some noise coming from the child. What is happening? So I think that was not enough of a clue. And with complete, you will not have any movement of the back. You will not have, any sound coming out as well, because it's complete glottic closure, right? And this is when you have desaturation. Definitely desaturation will be there, and some amount of bradycardia as well. Now, how do we manage laryngospasm? One, of course, call for help. The second is you have to always make sure that your oxygen is ongoing. Just make sure that there's no other problem. I mean, sometimes you can run out of oxygen, sometimes the tubing may have come off, whatever it is, just make sure oxygen is ongoing to the child. Two things you need to do. One is remove the triggering agent, and the second is to break the spasm. So what are the triggers that you know for laryngospasm? Secretions. So in this scenario, did we provide an oral suction? Could have done that. Okay. Remove the triggering agent or the device that may be. Sometimes the LMA itself, which is malpositioned, may be causing the laryngospasm. You may have to remove that. Okay. Then optimize analgesia. Remember, laryngospasm can happen during the surgery if your analgesia is not adequate. A surgeon is operating somewhere, you've given a caudal but it's not working. That is enough to incite a laryngospasm. Okay, so stop the triggering agent. Ask the surgeon to stop, treat the laryngospasm, and deepen the analgesia that you give your child. Okay, and of course deepen the plane of anesthesia. Usually it is an IV agent because the glottis will be closed. You won't be able to give sevoflurane or an inhalation agent. Strategies to break the spasm. Of course, you have to ensure a patent upper airway. Continuous airway pressure. So, what do you understand by that? Is that the same as positive pressure ventilation? No. Pranati says no. Let me see no.
Positive pressure ventilation is an intermittent positive pressure that's being delivered. There is continuous, and also the patient is breathing spontaneously.
Nearly. So continuous positive pressure ventilation, when you're not giving a positive breath to the patient, but you're creating a positive pressure within your circuit up to your bag. Okay, that is likely to break a laryngospasm, not positive pressure ventilation. If you give positive pressure ventilation, where is it going to go in the presence of the laryngospasm? Esophagus, stomach, and it will cause distension. So what you need is continuous positive airway pressure, not positive pressure ventilation. Then there are other techniques that you can try, like the Larson's maneuver, and of course the ultimate thing is muscle relaxant, which will break the spasm. Usually it is succinylcholine. You don't need a high dose. A low dose is more than sufficient. 0.1 milligram per kg is also sufficient. Most often we go with quarter milligram per kg, 0.25 milligram per kg, that's more than enough. There are various other techniques that have been described to break the spasm. I would not recommend tracheal intubation against the closed ports, but that is a last ditch attempt. If nothing else works, it's quite traumatic to do that. You would not do that as the first option at all. And if nothing else works, you have to do a frontal neck access, which is essentially a tracheostomy in a baby. Okay? Nasocryptectomy is not the way to go in children in less than 8 years of age. Remember that, it becomes very difficult. Now what if we don't have a patent IV? Child is moved around, IV is gone off. What can we do? No, you are already in laryngospasm. In laryngospasm, and your IV suddenly you see there's a bulge. Intramuscular you can give. If you have an intraosseous line in place, but remember that also takes a little time to, so you want it to act quickly, right? So intramuscular is an option, right? What is the dose? 4 to 6 milligram per kg of succinylcholine, not a smaller dose that you take for IV. What if you have a child who has a contraindication for succinylcholine? Say muscular dystrophy. Procurone can be used. How much? Yeah, you have to use a higher dose because you want it to act quickly, right? Even the higher dose takes about a minute to act, remember that. So you can't be giving a mosquito dose of 0.3 milligram per kg. You need the higher dose, 0.9 to 1.2 milligram per kg. Right. The other thing that you need to do is remember that all these problems are associated with complications. So what are the complications following laryngospasm that you can think of? 3 main things that you need to look for, at least. I mean, there are lots of others. Yeah. You had one, 3 or 4. You had one on table. You had some bradycardia happening. Hypoxia is a trigger for bradycardia in children. Very, very commonly seen. Okay? Yeah, bradycardia may happen, and secondly to hypoxia, you can have hypoxic ischemic encephalopathy and so on. Yes? Negative pressure pulmonary edema. So that may be there, you need to auscultate, look for it in your child. If that happens, what do you do? Supportive ventilation, supportive methods, yes. What else? Anything else that can happen?
Child can go into laryngospasm again.
Can go into laryngospasm again, which is why you need to have strategies in place for your extubation if you're planning to intubate. In the presence of complications, you may have to go ahead and intubate the child if not already intubated. So you need to have strategies in plan for extubation. How are you going to extubate this baby who's gone into laryngospasm? I think I put up some. So one is deep extubation. Of course, this is when you have a normal airway, right? Awake, no touch technique. Anybody knows what this is? So this is essentially where you make sure your oral airway, there are no secretions, you clear out all secretions, you keep the child lateral, you reverse your muscle relaxant completely, and you deflate the cuffs, wait for the child to not touch. That has the least incidence of laryngospasm. Extubation this way. This is a no-touch technique. And of course the artificial cough, which is all practiced quite often, that is a positive pressure that you give as you pull the tube out to remove the secretions. Right. Any other complication of laryngospasm? Can you have aspiration? Right. All this positive pressure that you're giving, where does all that go? Into the stomach. You may have given some vigorous breaths to try and relieve the spasm. Where does it go? Into the stomach. So you can have aspiration in these children. And the other thing that you need to be looking for is a distended stomach itself, because that can impede ventilation to a great extent in pediatric patients. Okay? So, go back one, sorry. So I think the next one, sorry. I think we've been through all of these complications. I'll just go to the references slide now. There's something called the PD Crisis Critical Events Checklist that you can download onto your phones. It's got a version for the Android as well as the iOS. So if you download that, and if you have an 8 kg child, you just put in 8 kgs and it will give you for each scenario what drugs you need to be using. So it is divided critical event wise. I think they have some 20 odd critical events, including laryngospasm and a whole lot of things. So it's a quick reference guide for you. Do you have any questions? Any comments? So differential diagnosis for hypoxia on table in a child. Can we just revise quickly? What do you think? Okay, laryngospasm will broadly come under obstruction, right? Yeah. So you remember your Dope's mnemonic? What is Dope's? D? Dislodgement. So the tube can go in or out. Yeah. O is obstruction. Obstruction can be kinking. It can be without an airway, without an ET tube in place. It can be just laryngospasm. That's obstruction. Yeah. What is P? Pneumothorax. So always review your ventilator settings to make sure that you're not, blowing up the lungs of the child. E. Equipment failure. Okay, so you can have a bag that is not functioning properly or an oxygen source that is not good enough. And what is S? Stomach. So again, stomach can be distended. Also in children, if they are on the ventilator, make sure stacking of breath doesn't happen. So that's the other thing. Any questions, comments, queries? Sir?
I was just thinking as you were talking about laryngospasm arising from various sources. We talked about all the reasons why laryngospasm can come from reasons around the larynx. But from outside, there are some surgeries like Lord's dilatation, cervical dilatation, anal dilatation, cervical dilatation, especially in a non-pregnant uterus. These can also initiate reflex laryngospasm. So these are extra laryngeal sites that can create a laryngospasm. So don't think of laryngospasm only in the context of the stimuli around the airway. You can also have it in these kind of surgeries. And very often what happens is you think, okay, Lord's dilatation, let's hold a mask. And then you have a laryngospasm. Just think of some extra laryngeal causes also for laryngospasm. Thank you.
Of interest, does anybody know what the reflex is called?
Which is good answer. Okay.
What is the full name?
It's quiz continuing.
What's the question?
What is the reflex called when you have laryngospasm secondary to dilatation of the
From extra laryngeal sources. It's a hyphenated word.
Yeah.
D-L.
Something for you to go look.
Yeah, you will think about it. Okay. Somebody gets the answer by the end of the day.
I'll give you.
I was just going to edit and have a chocolate in my pocket. She'll give you something.
No, I know the answer.
You can't say.
Okay. Thank you. So are we going on to the next scenario?
Yes, we
yeah.
can.
So you can introduce, I think, Thomas scenario.
Okay, all the ones can come forward, please. All the ones.
I'm Anurag, second year resident with Kamini.
Loud, see, this is what we tell you. Loud.
Light.
I'm audible.
Yes, better. Thank you.
I'm a second year resident. My name is Anurag. I'm from Kamini, Hyderabad.
Hello, I am Vinay from KMC Manimal, second year resident.
Hi, I'm Manish, first year from KMC Manipal.
I am Divya, first year resident, KMC Medical.
Hi, I'm Dr. Pallavi, third year resident, KMC Mangalore.
Hi, I'm Anisha Chris from GMC Vellore, second year PG.
So this is the trauma scenario. So let's come out of the OT and go into the emergency room now. Okay, I'll give you the scenario. Before that, the ground rules that Nisha ma'am has already said remains the same. What the management can do and cannot do is clear, I hope. So we can ask for vitals, we can attach monitors. IV is already in place, you need not put another one. You can verbalize if you have, if you want any monitor or if you want an investigation or whatever is required or equipment that you need, you can verbalize. If it is suitable, we will provide or we will let you know. Okay, so it can be, everything has to be verbalized. How much you are giving, what drug you are giving, everything has to be said clearly. And okay, so I will give you the scenario now. A patient, a 34-year-old male patient weighing 75 kg, who has been in a high-speed frontal motor vehicle collision. The patient was the driver and he was restrained with a seat belt. Airbags have been deployed and he was not ejected from the vehicle. So the patient is being brought in by the paramedics and is unresponsive and fail according to them. And the patient is on the way, so you have few minutes to prepare yourself for the arrival of the patient. So you can keep things ready whatever you want, what you are anticipating, and we can be ready for the arrival of the patient. So we'll assign the roles. We need one consultant, the team leader. Who will be the team leader? PG can be the team leader. And there can be 2 postgraduates. And one of the Vinay can be the and we have one nurse from our side, that's Dr. Prithvi, who will lead in case we are getting lost. And one more nurse, one technician. Ma'am, can you on call? Surgeon. Or a surgeon or an orthopedician is on call. We will go on with this level. We can prepare.
As we know that an acute trauma patient is coming up, so to be ready for the critical case, first of all I will need all the monitoring devices to be ready in the emergency. All the emergency drugs like ibuprofen,
Shall we check simultaneously?
Two postgraduates are there. One of them can manage the airway equipments. Just keep ready with all the airway adjuncts, SCDs, APGAP, suction, and different sizes of ET tubes. And the diagnostics, check the diagnostics and everything, check suction. The other postgraduate is in charge of the drugs. Just keep all the emergency boxes, adrenaline, all the induction, we need to resuscitate the patient, so keep all the iron fluids and adrenaline, vasopressors. And we need a cervical collar. We are suspecting cervical spine injury, so I need some hard load also. I need a hard load with a cervical collar, and one person should be able to provide manual inline sterilization. And ultrasound, if we can get for a EPA scan, we can do that.
Yes, ma'am. We'll call the ultrasound.
Yeah. And can you please contact the on-call surgeon and the orthopedician in case we have any open injuries?
Inform the on-call surgeon. He's in OT. He said he'll be available. Patient clear.
Patient has arrived. Just please connect the monitors first. We'll look at the vitals. One of you please start securing a IV access for the patient. Check.
IV access is already.
Check the response of the patient. Hello? Are you awake?
Mama, check the response. Only to the
Connect
pain is
monitors.
localizing pain and only to the pain is opening eyes.
He's just opening eyes to pain.
And he's only localizing to pain.
So his GCS is less than 8 IVs. We have to secure an airway. First connect to monitor. Start pre-oxygenating. Start pre-oxygenating the patient.
I'm hearing some sounds from the
One second, you just suction the airway once.
We'll connect the monitor.
to the BP monitor. It's reading now.
Suction on. Suction.
Is there any bleeding is there? Is there any bleed is there? Keep suctioning. Oxygenate the patient. How many IV lines do you have?
Only one IV line. Which is 18 gauge.
118 kg, yeah. Can you secure one more whiteboard cannula? 116 will be.
I've secured the 60 gauge cannula.
Is Jesus what is the BP right now? Measuring.
BP are measuring, ma'am.
Yes. Connect the oxygen source.
100% oxygen is connected.
Is it picking up?
Ma'am, saturation is
Still falling down.
Okay. Just put the
Airway.
You've started the IV.
So much of blood loss. We will be.
Yeah, rush
Yeah.
IV.
Is pulse palpable now? Is it feeble? Is it feeble? Yeah. We're giving fluids. We are rushing the fluids. Pressures are still low side.
Yeah, we can ask for blood. We have to send for cross matching. We first send the sample.
Ma'am, saturation is dropping.
Yeah, now we will secure the airway first. And one of us can give
I'll be giving drugs.
his GCS is already.
In 70 cases we can give up to 17.
Shall I put the 6 pack stabilization?
Ketamine, we want to give ketamine.
Shall I put the 6 pack stabilization?
Yes, but what if he has some given 50 kg? ICP might be injury might be there. So I won't be.
You don't want to give, so what do you want me to give?
Etomidated am I not audible?
Okay,
We have intermediate.
Okay, how much I give? First, I think we should start with midazolam. I think we can give 1 mg.
Accommodate, how much do you want me to give?
0.3 mg per kg, 75 kg.
Yes.
Given?
Shall I give muscle
We'll go for
GCS is already poor.
Do you want to give a muscle?
We can
He's taking up right away. He's not responsive.
yeah, I think we can just try. Look.
Suction.
Can you see the cords? Are you able to visualize? Please provide manual movement documentation. Okay, we'll oxygenate.
He's still awake. His eyes are moving.
We'll check, no? We'll check. And one of your Oscar lead the patient.
Have you connected the ETCO?
We have ETCO2. We don't have ETCO2.
We have ETCO.
It's sort of connected.
Can you please connect it?
Yeah, I'm also
Is the BP improving?
No, ma'am. BP is the same.
I think you can know.
We have ETCO tracing. It
airway C. Is it in? It's in one.
It's more on the left.
Okay, then at what level you have fixed it to? I think we pull it up.
Yeah, I'm not hearing any R. There's no R entry on the right side. There's only R entry on the left side.
Could it be this pneumothorax on the right side? I think call for
Need
I see
decompression.
maybe that's the reason for the hypertension.
Ma'am, saturation is still 87%.
I think we
Need
do a
decompression.
I'm going to a needle for a costume and in the fifth intercostal space in the mid-clavicular line, 1 centimeters lateral to the mid-clavicular line.
Gusher sound like gusher for the
Yeah,
Just continue to the mid axillary line.
yeah, saturation is picked up. Okay. And that's the percentage of that.
Yeah. Pressure back.
The BP hasn't improved yet.
We haven't sent any blood for investigation.
We have sent it.
Yeah, sent
Results, have you got the results?
Ma'am, the hemoglobin was come as 6.
We will
Can you
connect
range
it.
to
O negative. O negative we have.
Then we can start blood transfusion.
Yeah, we will be connecting pressure back. And we can connect it to the wide bore cannula blend.
Ma'am, saturation is dropping again. I'm setting the advanced window ultrasound machine. Saturation is 80%.
Then ICD is the recent ICD.
Can we call surgeon?
For
Yeah, orthopedic surgeon is there.
Then head-to-toe examination at least we can
Yes.
we should look for any other
Pelvic tract.
ICD.
We catheterize them in the meanwhile. Can we catheterize them?
Yeah, there's a femur fracture. Open femur fracture is there after you just ask the orthopedician to come.
That is limited to the
Compress. We have a splint.
So basically, he's a 34 years old male patient, weight of around 75 kg, came in India with history of trauma. There was lots of blood in the airway. We have intubated the patient because right now he has right pneumothorax.
Oh, it's got stomach injury also.
So ICD, yeah. ICD is now picking up. Can you please do an ICD?
Ma'am, there is only leak from here also. I can see blood on the floor also. There's a lot of blood on the floor.
Saturation.
Shall we come this?
Let's do the ICD.
Column.
Water pulp is moving.
Column movement I can see.
Pushing up now.
You had asked for the ultrasound, no? Ultrasound has come. On the right upper quadrant views, no?
Right upper quadrant.
Black color pockets
Yeah.
are there.
So there might be abdominal bleeding somewhere. Yeah.
Call for surgeon.
That's all. But I'll just scan.
Surgeon.
Have you started the oral infusion? Is then you
Yeah,
are
we have
getting
started
the
oral infusion.
blood you have started.
Tablet we have started pressors.
We should shift the patient to OT for exploration, but first we have to
Rate seems to be dropping. Let's keep the
Atropine is
Keep atropine level.
yeah, ready.
BP is reading again, ma'am.
Outline, sir.
What are the findings there?
Outline.
First, what are the findings?
I just scanned the right
Okay, hemoperitoneurosis. Yeah, we have hemoperitoneurosis. We have hemoperitoneurosis. We have fracture femur, head injury. Do we have an ABG? We need
What
to
the
inform
arterial
the
line
board.
right now?
ABG has come.
Arterial
pH
line.
is 7.2, lactates are elevated, PCO2 is 35.
I think we need to give him some more blood.
The blood pressure has come 102 over 60.
Have you started? Blood is
Blood is on
flow.
flow.
What are the findings?
This is subcostal.
pericardial effusion.
Ma'am, I sent the images to the CT-based surgeon, he said it's okay.
Because it's possible to get more. We called for a surgeon, we called for testing you for a CT, testing for a CT, is it stable enough to shift? Can we shift him to CT emergency? I think his BP is
BP is still low.
Right now, what is the BP right now?
BP is around now 90 over 60. Blood is going on and we are fastest forward.
Can we have to right? Can we take him for emergency?
Yeah.
Yes, ma'am. I have booked the OT.
Emergency OT.
It's booked.
Okay.
Now his BP is 100 by 60. I think we can, with the oral infusion and the resuscitation fluids, can we shift him for emergency safety today?
Okay, ma'am. So we'll shift to CT on the way then. Yes, ma'am. Selection.
Anesthesia team is in.
Anesthesia team and surgery team both are. Just
So, we got the prior report regarding an emergency trauma case, which was about to arrive in our hospital setup in the emergency room with the anticipated cervical spinal injury or any hemoperitoneuum or open fractures and head injury. So, keeping all that in mind, we started preparing ourselves to receive such a patient. So keeping in mind, we kept the monitors ready, all the emergency equipment, airway equipment and the emergency drugs with the oral infusion and adequate IV fluids. And we had already informed all the on-call surgeons and the orthopedician, anesthetists, and obviously the intensivists we were there. Plus we had asked for an ultrasound for a quick EPA scan. And once the patient arrived, we quickly connected the monitors, checked the GCS, secured two wide bore cannulas, started fluid resuscitation, and we were continuously monitoring the vitals, and we were ruling out the causes. And I felt we should have done the HEC2 a little prior to at what level we did, but that I felt we should have done immediately once the patient had stabilized a bit. And
thank you. Can you pass the mic? So let's start with the preparation stage. How did you go about preparing? You had a call that the trauma patient whose pain is coming in. No? So how did you go about the preparation?
So we had our airway equipment ready, our emergency drugs ready, we had fluids ready, we had also asked for blood O negative, and we had a cervical collar ready because the patient coming with pain probably had a cervical spine injury.
Did you use it?
After intervention.
After long?
Yeah, we could have kept it there immediately after.
So your preparation was quite good, you went thoroughly. So one thing that when we deal with trauma patients, we always talk about A, B, C, D, E. right, which we will come to. So your preparation also can go as airway, breathing, circulation, disability and exposure. So in airway, you kept the airway equipment ready and the drugs ready. In the breathing, you know that it's a trauma patient. So potentially what all instruments you might require? Needle, ICD, then the water column, right? Then you go to circulation. So in that you very nicely kept whiteboard, IV cannulas ready, fluid as well as the blood. And you also alerted the surgeon on that. Disability, any instruments you would require? Disability is actually not regarding fractures, but disability is the brain status. Right? So here probably a torch you would keep it ready because you would like to check. Right? What about exposure? What would you like to do with that? Okay, we'll come to that. Log roll is not a part of exposure, but in that point you want to limit hypothermia. So after exposing, you do not want them to, because all the places that ERs as well as OTs will be very cold. No? So at this point, as a preparation to that, you will ask them to increase the temperature of the room because we do not want to get them hypothermia. Right, great. Okay. So that is a part of the preparation. After preparation, you guys did a lot of steps. Okay? Most of them, like you had all the checklists which are there, which all of them got. But is there, and when a trauma patient comes, a systematic way to go about approaching a trauma patient? What is it called as? Primary survey. Right? So I'm from the emergency department. So there is a joke amongst us that we teach our kids A for airway, B for breathing, C for circulation. Right? So that is how much like we follow the ABCDs. So whenever you go for a trauma patient or in fact any emergency patient, we ask to follow the A, B, C, D, E. Why? Why not do the shock management first? Why not go to the disability first? Why is it followed A, B, C, D, E? So we deal with whatever kills first. So if the airway is compromised, will the saturation come? No. If there is shock, will the patient be able to have a medication? No. So that's why, as the killers are this way order, that's why we always deal with airway, then we go to breathing, then we go to circulation, then disability, then exposure. So even though now we have horizontal resuscitation, that is multiple team people are there, and she had actually rightly allotted one person for airway, but still the team leader always talks from A, B, C, D, E, so that you do not miss any steps. Along with airway, is there anything else that comes in trauma, which you guys mentioned just now? C-spine. C-spine, very good. Why does the C-spine stabilization come here early and should be the first step that we do with airway assessment and not later?
Because of the airway manipulations during intubation leading to the worsen the...
Excellent. During the trauma assessment itself, there is a possibility that the patient's cervical spine might move with all the interventions that we are doing, and also the patient himself might be moving. That's why the first step when the patient comes is airway with C-spine stabilization. So as soon as the patient walks in, you call this the ATLS walk. One person goes in and does the manual inline stabilization, when the other person goes and puts on the cervical collar, and then you proceed with your, continue with airway assessment. So airway is always with? Airway is always with? C-spine stabilization. Okay. So when we talk about airway assessment, can you tell us how you proceeded with the airway assessment and management?
First, externally we will see like any trauma and all.
Very good. Inspection. So inspection, you checked if any OMFS trauma is there, neck trauma is there. Very good. Something else you were asking also. Yes, you saw that blood was coming out. Very good. You checked for any foreign bodies there. After inspection, what did you do?
Like since it was bleeding intraorally, so we suctioned first.
Very good. So you heard gurgling sounds which were coming. So you started suctioning. Very good. After suctioning, are there any airway maneuvers that you know of which could help us to have a patent airway? No, not that. Yes. So in this trauma patient, because we are suspecting C-spine, you wouldn't do a head and chin lift, but you would do a jaw thrust. Right? So then you would go for airway maneuvers. Suppose even with that the patency is not there, are there any airway adjuncts that you can use? Yes, oropharyngeal airway. Nasopharyngeal airway can we use? If there is mid-phase trauma, then you do not use a nasopharyngeal airway. Okay. And then you proceeded because the patient's airway was still not maintaining, blood was coming and you were suctioning, you went for intubation. Right. I think there was a lot of confusion regarding what drugs to use and what paralytic agent to use, etc. Right? Okay. So, but finally you succeeded in intubating the patient. Now, whenever you are doing the airway assessment, always remember neck is also part of the airway as well as breathing. So you assess it twice because there might be any neck injury. Part of the airway is housed here, right? So that itself also you have to take care when you're talking about the airway. So we finished airway with C-spine stabilization. What's next? Breathing with ventilation management. Can you tell us how did you, you spoke, na? Can you tell us about how we go about the breathing with ventilation here?
Here we have done the needle thoracotomy.
No, why you did that? How did you assess?
We assessed for the auscultation we did and then breath sounds we did and then...
So breathing also you go inspection, palpation and auscultation. So what do you inspect? What do you find? Very good. Here in this patient the right side was not moving. That itself gives you the first clue. Very good. Also you will look if there is any open pneumothorax, wounds are there because that also becomes an emergency. Right? Along with that you also continue the neck assessment also, breathing. After that what do you palpate for? Very good, very good. The tracheal deviation. You want to know tracheal deviation. You identify that there was a pneumothorax. So for calling it tension, what do you need? Circulatory collapse and mediastinal shift. So trachea deviation is something that you would look for, right? What else?
Hypotension.
In circulation, but yeah, circulatory collapse you would look for. And then what else would you look? Subcutaneous emphysema. Yes, that would also kind of give you a clue that there might be either an airway injury or a pneumothorax which is there. Okay. Then auscultation. Percussion, it's little difficult to do in ED, so we skip that sometimes, but if you do, it can help you for hyperresonance or dullness. Next you did the auscultation. You found that the right side was decreased. So what did you identify? Yes, breath sounds were decreased. So you identified pneumothorax on the right side. In this patient, because shock was there and tracheal deviation was there, you categorized it as tension pneumothorax. So in such situation, do we proceed for an X-ray? You have to immediately act. Very good. Where do we do the needle decompression? Yes. How many of you say fifth intercostal space? How many of you say second intercostal space? Second, how many?
Put your hands up and we will join.
How many say fifth? Once you're not answering, no coffee.
You can't sit on the fence.
Right? So actually both answers are right. In pediatrics it's second intercostal space in the mid-clavicular line. But here we were dealing with an adult trauma. So it's fifth intercostal space anterior to the mid-axillary line. So this is a recent change in the guidelines. Before it was in the second intercostal mid-clavicular. But they found that the success rates were lower. So now for adults they recommended the fifth intercostal space anterior to the mid-axillary line. Once you did that, you got a gush of air. Does needle decompression solve our problem? It's a temporary measure. So what do you do immediately after that? Immediately you would proceed for the ICD. After putting ICD, you ask for air column movement. Is there any other question that you need to ask? Very good. You also want to know whether there was a hemothorax. So you will ask about if there was a blood along with the air, and if so, how much is there? Because if there is a massive hemothorax, that itself could explain your hypertension. And that is an indication for going for thoracotomy. If it is like at the insertion itself it's more than 1.5 liter or every hour it is more than 200 ml like that, there is criteria which indicates that patient might require a thoracotomy. So you will ask for these both things, right? So once you intubate it and you put the ICD, patient saturation improved. What's next? Airway C-spine done, breathing ventilation done. What's circulation? Very good. So is circulation always tagged with something? So So suppose there is no water at home. Okay. So suppose you fill the pump, but you keep the tap on. Tap is on, and you are filling the pump. Very good. So whenever you say circulation, it's always with hemorrhage control, right? So how do you start the management of circulation? Very good. 2 by 4 IV cannula. While putting cannula, can you do the blood test?
Yes,
What test?
Cross-matching.
Grouping cross-matching. ABG, very good. CDC. Coagulopine, we can do all these things, right? Once you do that, what do you want to start the patient on? Okay, very good. So you want to start on crystalloids. Can I give 3 liter crystalloids? 4 liter? 1 liter. So current guidelines say that up to 1 liter of crystalloids you can give. The crystalloids that are generally available are very cold, no? Do we want the patient to become more hypothermic? No. So you always say 1 liter of warm crystalloids is what you want to do. After that, what do you want to start? Blood pressure. So, okay, is there any role of colloids in trauma? So it's crystalloids, then blood. Okay. As such, hetastarch, I don't think we use it anyway for anything because of the increased kidney injury. In this particular patient, after crystalloids, you directly go to blood. I noticed that there was talk to start noradrenaline. What is the role of noradrenaline in a patient who is bleeding?
It is a vasoconstrictor, a generalized vasoconstrictor. Probably it contributes to stopping the bleeding. And it also elevates the blood pressure. It's a vasopressor.
So, NORAD or any other vasoactive agent would be a last ditch measure. Because in this patient, you know that why is the physiology having hypertension? Because there is no volume. So what do you need to do? Right. So you would focus more on crystalloids 1 liter, start massive transfusion protocol. I think soon you'll be discussing about MTP also. Start the massive transfusion protocol and go for hemorrhage control. So NORAD would come somewhere much more down the line because you know that the pathophysiology here is that blood is going. Right? Great. So that was regarding the circulation and hemorrhage control to start with. Now, right. So we were talking about the patient having shock, right? So what is the most common reason for shock in a patient of trauma? Hemorrhage. Very good. What's the second most common cause of shock in trauma? Obstructive cause, okay. How many of you say obstructive cause? Okay, what are the other causes of shock in trauma? Very good, cardiogenic shock then. Neurogenic shock, okay. So how many of you feel the second most common cause is pneumothorax? Raise hand. First common cause is hemorrhage, we agree? Yes. Second most common? Neurogenic. It's also hemorrhage. Third most common? It's also hemorrhage. So please remember, when you have a trauma patient who's in shock, until you do all your efforts to find a source of bleeding, you are less likely to attribute it to other causes. Pneumothorax, like ma'am rightly said, you would have already picked up in airway breathing, hopefully. Right? You would have already sorted that issue. And definitely, yes, that is something to be considered. Morning, Ramkumar sir was telling one case where there was bradycardia and shock, which would also point to neurogenic. But all this is after you have done all the efforts to find the source of hemorrhage, controlling it, right? So the most common first, second and third cause is hemorrhage itself, right? So we said that with the hemorrhage, blood, everything, you also have to do source control, right? So here you saw that there was blood on the floor, right? So that is the external bleeding was there, which you kept the compression and all. Whenever there is blood on the floor, how do you look for the other causes? Where all do you look for?
Scalp.
Yeah, scalp injury also external. So they say blood on the floor, look for 4 more. So that was the external one. So what else will you look for? Where will you look for blood? We discussed one already. Okay, fast scan, very good. So you look for abdomen, very good. We did this discuss. Very good. So long bone, where else? Hemothorax after putting ICD. One more, very important. Commonly missed? ICD, yeah, chest. So you looked for chest, you looked for abdomen, then you look for pelvis. Very good. Open pelvic book fracture can accommodate the whole volume of your blood. It can be that much, right? So unless you put a pelvic binder in the initial stages when you're suspecting it, patient can examine it because of the pelvic fracture itself, right? And then also the long bone injury is the one where you look for. So blood on the floor, look for 4 more: chest, abdomen, pelvis and long bones. So here you looked for it, so you can rightly ask for fast scan. You probably would have also asked for chest and pelvis x-rays here, right? And then long bone you did the splinting very well, so that was good. Okay, that was circulation. After circulation comes disability. So what does disability mean to you? Very good. So it's the sensorium. So you look for GCS. Here you had already assessed it, so there was a poor GCS. What else did you check for? We discussed in the preparation. Very good. It's very important to check the pupils. Why? Very good. So what is one sign in pupils which will alert you that this patient needs urgent neurosurgery? Anisocoria. So whenever there is unequal pupils, you want to know that it's like a code brain. How you have code brain? It's a code brain where patient is having an impending herniation and immediately needs to go for neurosurgical intervention as well. Okay. So you check for GCS, you check for pupils. What else do you check for in disability? Log roll and all comes later. The only probable time where we do it in primary survey is when you are not finding any source of hemorrhage, you might do a log roll to see if any open wounds are there as a part of circulation external injury finding. Right? Otherwise it comes in secondary survey usually. You check for lateralizing signs. So you want to know if they are like not moving one side, right? Or like not moving both limbs. So lateralizing sign. And one more thing, important step, in any decreased sensorium patient, like anyone who's drowsy, like, what do you check for? Probably what she's having right now. No, not reducing. I mean, here you should look for it. But with her, I was referring to hypoglycemia, which ma'am's going to provide us with tea soon, so we'll deal with that, right? So hypoglycemia is something you will look for, right? So that is regarding disability, where you check GCS, pupils, lateralizing signs and sugars. After that you go for E, which is exposure. What does that mean to you? Very good. So you do a thorough external. So when you did that, you found that there was a femur fracture, there was an abdomen injury, right? And very importantly, now you have exposed the patient. They are lying there with no clothes in a cold environment. So you always prevent hypothermia, so you will apply warmers. Okay, so quickly ABCD. A is for airway with C-spine, B is for breathing with ventilation, C is for with hemorrhage control, D is for disability, E is for perfect. So once you do all these things, why do we do it one after another is also clear, right? Like I said before, since we are like a lot of people together, we sometimes do horizontal resuscitation where we say, okay, you take care of airway, you take care of breathing and all, but the team leader still thinks of A, B, C, D, E. So you think that always. So even now, like I'm in ED since I think 11 years now, I always go back to A, B, C, D. Whenever there is like somebody deteriorates, okay, what's happening with the airway, what's happening with breathing. So that actually helps a lot, right? And when all of us learn it, it's easy to kind of communicate also, and you know that that's the sequence, right? So that was regarding the primary survey. Now, there is something called as primary survey adjuncts. These are the tools which help us in the primary survey to find life-threatening injuries. So it's like 2 X-rays, 2 tubes, 2 tests and E-fast. Okay? Can you tell which 2 X-rays I'm talking about? Chest X-ray. Very good. Chest X-ray and pelvis X-ray. You'll know this if there's any smaller pneumothorax, you'll know if hemothorax is there. And then you'll also in pelvic X-ray know pelvic fracture. Don't miss out pelvic fractures. 2 tubes. No, ET tube is optional. No, if required only. What else? ICD is also optional. In polytrauma, Foley's and orogastric. Here we do orogastric because midface fracture, if it's there, it is a problem. So orogastric and like in previous situation, ma'am was talking about stomach extension, everything. No? So Foley's and orogastric. 2 tests. which you guys asked for? Very good. APG and ECG, because someone spoke about cardiogenic shock, right? And then E-fast. Can you quickly tell me what are the views in E-fast? What is E-fast full for? Extended. Focused. Very good. It's assessment. Yeah. Extended focus assessment by sonology in trauma. Very good. So what all do you look for in E-fast? Quickly. First view is subcostal, where you look for pericardial effusion. That around the heart, black color will be there. Okay. Then next you look for right upper quadrant, where you are looking at hepatorenal for abdomen, also hemothorax about diaphragm. Then you look for left upper quadrant, splenorenal and hemothorax. Then you look at pelvis, suprapubic. Very good. And because it's extended fast, what else are you looking at? What do you look for in extended? Thorax. So you also look for pneumothorax by lung sliding. Very good. So this was regarding the primary adjuncts. After this you proceed. So you can ask for this as and when required. Like for example, rightly so, in circulation you guys asked for E-fast because you found the shock. So you can use it earlier. But at this point, at the end of primary survey, if you have not done so far, this definitely has to come before you move on to secondary survey. Then you go to sample history, then secondary survey. Is CT scan a primary survey adjunct? No, it's a secondary survey adjunct. So you finish primary survey, primary adjunct, then secondary, then do a CT. Right? If required, if the patient keeps being unstable, probably OT is what is required. Right? Okay. Now finally, before finalizing, additionally remember, prevent the lethal triad of trauma. So make sure there is no hypothermia, prevent coagulopathy, prevent acidosis, and also calcium. Prevent hypocalcemia you need to look for. Right? So keep in mind about the temperature. Right? Any doubts? Any doubts?
Can I add something? I just want to share something. You might think, why is it important as anesthetists to do this? It is important because we do come across a lot of patients who come in for trauma surgery right from the ED. You're from Vellore. Do you still have the trauma list running? Yes. Yeah. So I'll share an experience that I had there. We used to run this trauma list 24 hours a day, and that is mostly the orthopedic surgeons who would operate on fresh trauma cases. It might be an open bleeding injury. In this particular case was not an open injury, but they wanted to operate as soon as possible. It was some 7 in the evening. Patient came in, we assessed him. We saw that he's complaining not of his leg pain, but his abdominal pain. And this is at a time when E-fast and everything was not yet, now everybody does an E-fast now. When I was training, that was not what it was. So I just opened his tummy up. He is complaining of abdominal pain. He is not complaining of his leg which is broken, femur which is broken. Opened out, there's one big bruise across his abdomen, and tenderness, guarding, rigidity, all that is there. So then we had to send him back, and then he had a E-fast that was positive. So even in your preoperative assessment, don't assume that somebody has done the job for you. Please do a primary survey in a systematic order, as Dr. Prithvi said, then you will not miss out things. If we had taken it up for a femur surgery, maybe he would have planned a spinal or whatever, I'm sure he would have crashed. He had a blunt trauma with a liver laceration. So we would have completely missed that, and we would have had a arrest situation or even an arrest. So that is the importance of doing this. Although you're not ED physicians, you need to know this.
Yeah. Also to add, many times initial E-fast can be negative, but by the time the patient comes to you for OT, the situation might be something different.
Yeah.
Many times EDH patients initially they will be conscious. We might have not done the CT, but later. So because trauma is so dynamic initially in the first few hours, it will become important to keep assessing them in this.
Good evening everyone. I am Dr. Arda from PMC Manipal, first aid unit.
Good evening.
Secretary. Dr. Ramka, second-year resident from Diploma Hospital, Candidate.
Dr. Juneju, second-year resident, Government College.
Good evening, I am Dr. Devavati, KMC Manipal, final year resident. Hello everyone, I am Dr. Bhavati from KMC Manipal.
Welcome. Can you just stand that side? I'll just put on one small presentation. So, myself, Dr. Priyanka and Dr. Rajaram will take you through the obstetrics scenario. First of all of you have had tea, right? And ate something. So, no NPO, full stomach, attentive, no sleep. Unless all of you were sleeping in the previous scenario. Okay, so before that, we'll have a brief layout. Okay, so what we are basically going to do, they've introduced themselves, I have introduced myself. Okay, we'll give you a scenario related to obstetrics. Okay, and you will just have to come here, act it out, and then we will discuss what could have been done, what could have improvised, or what was done well. Okay, assigning roles is equally important. Okay, so before you go there, we will give you some roles. Okay, and we'll give you some time to prepare the OT because our obstetrician is a surprise. Okay, I hope I'm not repeat. She's there. Okay. Then we'll have a scenario which is going on, and then we'll debrief, and then we'll give you a small tips and takeaways. Fine. So before that, I would always tell this, repeat time and time. What the mannequin can do, you can feel the pulse. Okay, both femoral and radial. If you auscultate, only if you auscultate, you can hear the breath sounds. Okay, you can intubate, you can put an LMA, but be gentle. You can also apply a suction. Okay, and in this scenario especially, we will concentrate on communication, verbalization, and how you work with each other. Okay, so I want you to tell everything loudly. Ma'am, we have put ECG, we have put the pulse oximeter, we have put IV, temperature or capno. You have to ask. If you just murmur, then it will be just counted as no. Okay? What has to be verbalized is again oxygen setting, like I'm pre-oxygenating 2 liters of oxygen or 5 liters, you have to tell. Okay? Inhalational agent, especially here, what you're going to use. Okay? How much you're going to use. Ventilatory setting, after you have intubated, you need to tell that. And please do not switch on the IV, just connect it, okay, and tell that, so that there is no leak, okay. So our objective is mainly to, as madam came and told you, she just told you what is category 1, correct? Can anyone tell me what's the category 1 section? Doctor?
It's an emergency section which is equally having impending.
So it's a threat both to the mother and the child, and it needs to be done as early as possible. So this is the case which is being allotted to all of you, okay? And for this you'll have to perform necessary skills and steps required to manage within a limited frame of time. Okay? And whenever you're telling any medicine, please do say the dose, the route, okay? And the right one. Okay? If you have a doubt, please ask your fellow Greeks. Clear instruction and communication. And again, last part which is very important in this scenario, that is the team dynamics, professionalism and respect for each other. Okay? So, this is the scenario. Shall I read it out for you? It's a 27-year-old, okay, who's G2, P1 and L1 at 36 weeks of gestation with history of high blood pressures. Okay? And she's on Lebetalol, tablet 100 mg BD. She has come to the LT with reduced fetal movements and little bit of vaginal bleeding, around 50 ml, and they have planned for a section as she's in the category 1. And she has some fetal distress and they're suspecting possible abruption. So you have a lot of hints here, okay? These are the lab parameters which were done 1 month back. They have sent the investigations, but most of them are awaited. You went through the file, but you saw these, okay? And these are her vitals, okay? So now this is the role assignment before we start, okay? So do you want anything else? At
current scenario, I'm just giving you these, okay? These are the lab parameters we have sent, they are not ready yet. These are our current vitals, okay? You are the team, okay? You have been called. You will have to give roles, okay? Somebody can be the team leader.
Obstetrician and obstetrician assistant is already ready.
Yes. Please assign role. Here, Devavati is the final year. You want to be the senior anesthetist? Senior anesthetist. Juneju, you want to be the postgraduate anesthesia? Ravita, you technician. Okay, fine. You will be the intern who will be running for the blood and all that. Okay, safe. You will be the silent observer. You will take care of everything and then tell the story in the end. Is it okay? Okay, Kathy, what will you do? Okay, you will be the consultant anesthetist. Huh? Will you be? Fine. Okay. So you have the mic with you. You take this. You are the help.
Devavati, you can come out.
She is the senior. No, she should be outside.
Stay outside.
Rules are clear. Rules are clear, huh? Okay, so now let me introduce you to our obstetrician, Dr. Vani. She's not coming. Okay? She's come for the surgery. Okay? She has given you a call. She's given you a call and she's telling, shifting the case immediately. You have 5 minutes. You have to keep the OT ready. So go to the OT, keep things ready. When you're keeping, please verbalize so that everyone will know, not only you. Okay? Not in a group, just one of you can tell loudly. Okay? What you're going to keep things ready. Category 1 cesarean section. Coming in 5 minutes.
There is ready also to whiteboard IV cannula is there. All the emergency drugs, airway devices is there or not. Machine has been checked or not. Oxytocin has been loaded or not. Please.
Three medications like metaclopramide.
Suction needs to be checked and kept ready. At the same time, ambuban also has to be checked and
keep all the BP apparatus, pulse oximeter, everything keep it. And in case they'll keep lower numbers, 80
Tell it loudly.
They'll keep endotracheal tube of smaller size also. We are expecting it to be mild now.
Pressure lag, IV fluid is there, and blood forms are there.
So right now the patient has been wheeled into the OT and the obstetrician has come in. And patient is saying, I'm anxious, please take me, what is happening?
Are you ready, doctor? See, I'm the junior most senior resident. And this is a very serious case. Please look after sir. Please. Okay, otherwise I'll get thrown out of KMC. Tell me when do I clean and drape? When do I clean and drape?
We'll connect all the BP apparatus, ECG, pulse oximeter.
I'm connecting the pulse oximeter.
And check for the patency of the IV cannulas.
IV is flowing.
Okay.
Patient's NQ.
What NQ? I don't know. She just now came.
She's the obstetrician.
You didn't ask?
2 hours. She just had idli vada and came. 2
Okay, we'll
hours
start
back.
the pre-medication.
See, doctor, she's bleeding. Fetal heart is down. I don't want to lose the baby.
Just give. Yeah, we'll go for RSI. First, we'll give ranitidine 50 mg and metaclopramide 10 mg. Will give us pre-medication as the NBM service is not non. And I'm pre-oxygenating the patient. 100% O2. Propofol is ready.
So what monitors are you at?
BP apparatus is connected. Pulse oxy is connected, and ECG is also connected. Be ready with the propofol. We'll give
Loaded, fully loaded.
endotracheal tube 7 and 6.5. Be ready. And plates are working right.
Yeah.
What are you doing?
What if you get ready for RSI?
What are you doing to me? What are you doing to me? The patient is saying.
I'm giving the picoid pressure.
Okay. Keep on the cervical stabilization also. Okay. Okay.
Somebody somebody is inducing or?
Okay, we'll go with that.
I'll explain the patient.
When do I explain the trip? Now or later?
We are giving some pressure, you feel some pain initially. So
Ma'am, just we'll just induce the patient after.
Okay.
Give her another metaclopramide, then propofol, 2 mg per kg. So we'll give her around 100-120
Tell it loudly so that we can.
Okay, propofol 2 mg per kg. As we'll consider 60 kg for this patient, we'll give 120 mg. Just pick me up.
Do we have internal?
And sevoflurane we'll keep at 1. Okay.
Scoring.
Yeah. Scoring 100 loaded.
we'll give considering it's 60. So
Intern, call pediatrician.
Pediatrician has not come.
Actually, PP is not coming.
It's ready. It's ready. Okay.
Pediatrician is informed.
Give us scoring.
Informed. Okay.
Give us scoring.
Scoring.
Scoring is given. 1 minute is done.
And you can start checking.
Okay, thank you.
One of you just check
Assistant,
the
just stand.
5 pointers.
Doctor, you left the tray. Never put it on the patient's leg. Sorry. I'm junior. Don't tell I scolded you. The HOD will scold me. Please pray for me, all of you.
Just check the tube is ready.
Ma'am, you can go ahead.
You're corrected the ATCO2?
I'm not ready with conversation.
Okay.
ATCO2
Just check the auscultation, 5-point auscultation.
Only if you ask, we will show you the parameters.
Actually, ATCO2 is not coming.
Chest times is there or not?
You inflated the cuff, right?
ATCO2 is coming.
Okay.
Relieving blood pressure.
I've only cleaned and ready.
Keep hand on the pulse.
When can I start?
It's step 1.
I can start?
you can start.
Okay.
See you will keep at 1.
Assistant, I'm imaginary assistant. Okay, I operate from left side.
Intern is there. One more IV cannula we can check.
I didn't even hear the fetal heart in OT. I was so tensed up. Baby, come out, okay? No pediatrician. There's nobody here who can help.
Seem to be ready.
Okay,
Oxytocin
just
5
run
mg bolus.
Somebody please.
Okay, go.
Give 5 mg bolus.
Oxytocin 5 mg bolus given.
Rest you can put on 1 point RM. 15.
On flow, oxytocin on flow.
Okay, BP is dropping.
Yes, uterus is very flabby.
Check for the
I'm
pailer
putting
is
one more
there.
IV cannula.
Yeah, one more is secured.
16 gauge secured. To rest the fluids.
I'm
Pressure
putting
cap,
I'll
pressure
give
cap.
you more.
It's very flabby. I'm massaging. Oh, just see how much blood loss. Do something to make the uterus like that.
I'll get the blood.
Giving
Pitocin. Okay, what else? It's still very, it's very relaxed.
Hypertensive, we don't need carbon.
Carbopros we can give. Intramuscular carbopros.
Carbopros given.
Pressure man.
fluid boils, please start.
Phenylephrine 15 like bolus can be given.
How much is the
Bleeding
BP?
is okay, ma'am.
No, it's bleeding like anything. Did you get blood?
Cold would empty.
I'll go get blood.
Okay. I think I have to proceed for uterine arterial ligation.
I'm putting an arterial line, the central line. We started inotropes and tranexamic acid 1 gram on flow.
Shall I start uterine arterial ligation?
Blood has got. Checked and check.
It's dropping, right? I have to go to Europe. I have to marry the Richard senior resident in medicine. How will I go? Please, I told you, help me. You are my classmate in MD. You senior resident. You I have to go to Europe.
Yes, ma'am.
Phenylephrine and bolus can be given.
Listen, we were taught if the BP is dropping, we all studying together. We have to do hysterectomy.
Ma'am, we'll go with the primary man.
Madam Jessica, Madam Professor, Madam. Sorry, Madam.
Actually, we have PCF 50
Okay, I will call for help.
Okay.
I have to proceed for hysterectomy. I don't know what to do. Ma'am, please come and help me. Okay, I will come in.
Calm down, ma'am. Just 5 minutes. We have called our senior. She's on the way. What has happened?
patient is having massive bleeding and the BP is not picking up.
No relaxation. No relaxation.
Babies are given Sindor also.
Please give me more relaxation.
I'm giving. Okay.
We can repeat them.
How much? One at a time. How much is the bleeding?
More than 1 liter now.
Okay. Has somebody activated anything?
Yes,
blood is started.
First point is good.
Okay. What's the BP?
BP currently is 69-39.
Okay, fine. Has somebody started rushing fluids?
Yeah, we already rushed 2
pints.
pints.
Okay. Whiteboard access is in?
Yeah, 16.
Second. Have you taken an EJB? Take an EJB.
Central line.
Madam, uterus is out.
Uterus is out.
Things are under control here. Madam,
Fine. Okay, start, do one thing. Start phenylephrine. Phenylephrine is ordered.
Bolus we have given 100.
How much has been given till now?
100 mg is given.
Fluid, how much has been given till now?
2 liter. 1 liter is good.
1 liter. Start rushing. Through 2 IVs are blood going.
Saturation is
And also inotrox is going. Tranexamic acid
Patient is
on
on 100% oxygen. What is the MAC?
MAC you kept at 1.
MAC, decrease the MAC, bring it down to 0.6 or 0.5. That reduced it. Do one thing, switch off the inhalation agent only. Put her on oxygen as of now. Let the oxygen take up for now. Okay, do one thing, start noradrenaline as of for her now. And second, how much blood has gone till now?
First point is on floor.
PRPC 1F.
Start rushing, do one thing. Get up, syringe and start rushing the blood for her.
You will extubate, no?
Ma'am, we will try.
I don't want my patient to go to ICU.
I understand.
You have to extubate my patient.
We are trying, ma'am. Output is there, just check the output once. Okay, oxytocin, second oxytocin. How much oxytocin are you given?
5 bolus and 15 bolus.
Ma'am, uterus is out, no?
Yeah, uterus is out.
Bleeding has stopped.
Please don't call me ma'am. I have to go for my wedding. The uterus is out.
Bleeding has stopped.
Uterus is closed also.
Bleeding has stopped.
Bleeding has stopped.
Okay, fine. Then let's wait. Okay, BP slowly picking up.
Rushing blood.
Start rushing the blood. Okay, FFP and platelets are also there, or only APGAP has come?
MTP we are there.
Okay, start rushing on both the sides. Pulse volume is. Can you please check uterus is out? Give one head also.
Ma'am, both parts, please. My flight is there to Europe. I have to marry that senior resident. I'm going, ma'am. Uterus is out. Please, ma'am. No, ma'am. Please, I'm going.
HP is 7.5.
Picking up. Picking up.
So we'll stop here. Please take that seat. Please give a applause. You did a very good job. How many of you have encountered obstetric hemorrhage? Proper last one. Abruption or so-called abruption. So when it comes to obstetrics, 2 things come into the mind. First is stress, next is time. Exactly, correct? It's usually a chaos, usually either it's patient or patient party or whatever. There will be some chaos and you have to deal with the patient immediately. And within very less time you have to take history. Did all of you take any history? None of you asked me how is the airway? Does she have any allergy? Nothing. She was just on the table. So consent, blood products, ICU bed, ventilator. Anything was mentioned like that? You think it's relevant? Agree it's relevant? They don't give you time usually.
Investigations were asked for. I always anticipate HELP syndrome, so they've not asked for the repeat platelet count, LFTs, RFTs.
That was 1 month back.
1 month
The report
back.
which was available was 1 month back.
Yeah. And it was sent. Some investigations were sent, but you didn't ask me what was sent. If you had asked, probably I would have told RFT, LFT. And I told you specifically when I put a scenario, there are few hints. What are those hints? Platelet 1 lakh. Other than that? Labetalol. Okay. Anything else? Urine protein. Okay. Anything else? Abruption suspect, vaginal bleeding, I told. That alerts you that there is some bleeding, it can go into PPH and patient may be unsafe. So when you see that itself, it has to come into your mind that, yeah, I have to be prepared for a general anesthesia. anyone for rapid sequence spinal in this scenario? An expert in spinal, I'll give one single shot. Obstetrician. One single shot spinal. Single shot, atraumatic. Patient is thin.
Risk of coagulopathy. There's a risk of coagulopathy.
How many of you are for spinal? Please raise your hands in this scenario.
And then see the platelets and
They will not. Obstetrician will just.
Platelet is awaited. The reports are awaited.
Yeah.
1 month back reports are platelets are normal.
So category 1 is a threat to the mother and child. There is no time. So they just wheel in. Sometimes even with civil clothes, they just get the patient. So GA will be your anesthetic plan. Okay. The minute they put the patient supine, our Kathy told someone important point. What was it?
Wedge is there.
Wedge is there or not? Is it relevant? How does it help?
Actually, it compresses the major vessel because of the
Major, what major vessel? Aorta? Does it actually, aorta, does it stress on the aorta? It's a misnomer, right? It is aorta cable. Okay, so that actually helps both the mother as well as the obstetrician. It helps in reducing the bleeding. So that is one thing which they rightly did. Okay. Next thing is they connected the monitors, they checked the IV, saw whether it was patent, and then the obstetrician came and told, shall I start? Shall I start? Then Rabita said, wait ma'am, will induce. Is it the way usually? No. Anyone wants to differ? Do you want to differ? What could have been changed?
Pain,
Yeah, you can tell it loudly.
pain and rape, then induce. At the same time, we can be deoxygenated.
Okay, very good. Very good. Okay. So that saves a lot of time. Okay. Meantime, you can start thinking, I should keep this ready. If this doesn't work, I have another plan. Okay. So that usually they don't give you time. Correct? So this particular painting and draping is the time when you actually will think, okay, I'll give this drug. Okay. I'll make sure that the blood pressures won't fall too much or go high, because this is a suspected preeclampsia. So your choice of induction is, what was the drug you used? Propofol. Propofol with scoline. Do you think you opioids? No. Do you think should have been given? No. How many of you are for giving opioids before the baby delivery?
I don't want respiratory depression.
Okay, fine. It can be done, but we have to inform the pediatrician that we have given the opioid. So you need to obtain the... No. After finish, I will discuss this. So you need to obtain the... Yes. Because that is the time when the blood pressures can really shoot up. So you have to give fentanyl, okay? Yes, madam, as you said, maybe you will use it with caution when you are doing it outside. Since we work here, yes,
I work in the periphery.
Peripheries, yeah. That's why we learn a lot. See, when we are interacting, we are learning a lot. Correct? So that was missed, I think. Opioid was not given. Correct? You didn't go to the narcotics and get it. Correct, no? Forgot. You are an observer, no? You are supposed to summarize, but you forgot. Okay. So after intubation, again madam was saying, shall I start? So some time was wasted there. Correct? So Kaplan was there. Generally you could have told, start ma'am, as early as possible. Because in preeclampsia, once the baby comes out, yeah, it will start settling. Not immediately, but yeah, that is how it is. The termination of pregnancy usually solves. Okay? Then what happened? Once the baby started coming out, what happened?
Uterus was not insufficient.
Madam started saying it's flabby, it's bleeding. So then reflexly somebody did. Divya, I think, he started saying we'll put a wide bore cannula. Correct? No, yeah, but before that I heard blood and oxytocin, carbocross, everything, isn't it? So do you give immediately all of them together? But the obstetrician will tell you, give oxytocin, give carbocross, give methergin. How many of you are for giving methergin in this case? Did you want to tell something?
Hypertension.
Okay. So methogen is given IV or oral or IM? IM. Always IM. What's the dose? 0.2 mg. Very good. What? Carbocross?
220 mg.
Super. Is it given IV?
IM.
So what is the precaution when you give carbocross?
So H2 of asthma.
Any people have to be very careful. You have to alert the obstetrician and say, look here, we cannot. Somebody was saying carbitocin, is it? I heard that term. No. Pitocin, I think you were telling pitocin. Okay.
Even carbitocin is an IM.
Carbocross. Okay. Carbitocin, is it used in any of your institutions anywhere?
Post-COVID, I don't know. During COVID, we used to have a lot of airborne PPH. And carbitocin worked. So that time we started using carbitocin.
As a routine. So most of the obstetricians are now asking us to give carbitocin.
100 mg per
Very important.
Carbitocin 100 mg per ml.
How do you give it?
IM.
And as an infusion, do they ask?
Infusion they do.
Manish, you want to tell?
It can be given as infusion, a slow infusion over 10 to 15 minutes, we can give carbitocin.
Why is it chosen? 1 minute. See, a lot of the times what they follow here, please go back and look at the literature, what it says. Literature says over 1 minute. Literature says 1 minute. So that's why I said, in my initial slides, it is the dose, the route and how you give. So there will be a lot of chaos. Thousands of people will put thousand thoughts. Like that's why we assign role when we communicate. And it's a closed loop communication. When she says you do and you tell. Yeah, I have given everything. Okay. So were you happy with the volume resuscitation? Sometimes some bleeding was happening. Then 1 liter of fluid was given. Correct, Naravida?
Check for DI, rule out DIC in that context. Should we rule out?
Excellent. Yes, we are coming to that point. So what do you want to do?
For D-dimer and FDP levels.
Yeah, but that level will come maybe 6 hours later, 4 hours later.
Can I give ECA prophylactically?
Okay. I agree with you, but anything else? Something else they started shouting. Rabida said, we'll do that. Think nobody told us. Before that she said something and Divya ran away. MTP. When you say MTP, it has to be very clear. It's just not in issuing blood. You say massive transfusion protocol. You alert the blood bank to send a person specifically for that. They start releasing blood and blood products. That is in the ratio of 1:1:1. So all of you are saying that. I heard that. PRBC, SFP, even the consultant asked. Call for help was informed in time or before time or late? Late? By then I think they had done a good job because we started.
Can anybody tell uterine blood flow per minute?
How much is the uterine? Pregnancy.
It's okay, they did. Yeah, I remember synchronous per minute I was told. So they'll bleed very fast. Okay, and one thing, this scenario is artificial because you're doing it in 8 minutes, no? This whole thing may take half an hour. Suddenly, unless somebody is really pouring, it'll take some time. That's why it becomes difficult for you all also to decide how much to do it. It's a little artificial because we shortened it way.
But all of you activated it and started doing. So that is a very good thing. And all of you thought of securing a central line and an invasive monitoring. And one of you actually saw the urine, which was very good during fluid resuscitation, which was actually, I think, a good thing. Yes. Urine output was. Then anything else? Investigations, any ABGs sent?
ABG we are.
Why do you do an ABG in case of bleeding?
The hematocrit and HP levels will.
Anything else which will guide you? Okay. And anything else? The pH, does it tell you anything? Acidosis. What kind of acidosis will be there? Metabolic. Correct? Agree with it?
How many anesthetists were there in that team? All by anesthetic. No, you said one is technician.
Yeah,
no,
tell.
In the team. No, I was not listening. How many anesthetists were there?
2 anesthetists. She's the senior one.
So when the pediatrician is not there, no, I am saying, one of you, even if BP is dropping, one of you should have gone to resuscitate that baby. That baby is asphyxiated, pediatrician is not there, no? So you also should be aware. As much as me, you should be aware. Okay, you can't wait for the pediatrician because you're in a hurry, but then at least one of you can take out the baby, no? Obstetricians don't know anything how to resuscitate baby.
No, that's a very real scenario. We've had to resuscitate babies.
Because we don't know how to intubate or anything, no? We are frightened actually. So you all know, no?
So anything else? Any investigations did you review? Madam said take and all, which is a very good thing. Okay. She sent investigation. But anything else? Did you review the previous investigations which were sent? Yeah. So it's always better to keep updating and finding out if any lab parameters normal, abnormal, because sometimes you suddenly know that the platelets is 50,000, then what?
So with the 2 anesthetists, the assistant anesthetist should have been checking all that.
And at any point of time, did you think of putting a temperature probe and monitoring the temperature? Was it missed or you think it's relevant?
Blood transfusion. So hypothermia.
Yeah, so when you're giving a lot of blood, patients can actually go into hypothermia. So if hypothermia happens, it's good. Why?
We just got the lethal trial.
So what can it cause? Again, it can worsen. So you don't want that to happen, correct? When you give a lot of blood, what else can happen?
Calcium levels.
Hypocalcemia.
Yeah, because you've given a lot of citrate, correct? Yeah, so then tell a lot.
Citrate will bind with the calcium, so hypocalcemia.
So you will have to give what? Calcium carbonate. That is usually after how many transfusions?
10 units.
10 units is massive transfusion, usually over 24 hours. It can go up to 20 also. Okay. But after how much blood transfusion? Say I give 2 PRBC, do I need to give calcium?
Over the time period in which it was given.
But this is like a abruption, you will be pushing. I saw somebody pushing it like. Any answer for that? Deepavati.
Against doctor, if it's in an emergency situation, depending on an APG, but in some elective cases, like if the surgery is going for some 3-4 hours, that time we'll wait for an APG, and depending on that time, we'll take a call.
So yeah, that brings to the transfusion again. How is your resuscitation going on? You keep doing the ABG, seeing the lactates, then the pH. Okay. At the same time, you see the patient that the systolic has picked up. We stopped the scenario when the systolic started coming above 90. Okay, and the urine output was adequate. Then we also targeted the heart rate, and you see that it's slowly coming down. You know the patient is being revived, which is doing okay. And the last part is the extubation, which Jessica rightly pointed out. Most of the time they'll push, please extubate, because they know that the infection can be really bad, febrile sepsis or whatever in ICU. So definitely they'll want the tube out, but you can always tell we'll extubate, shift her for monitoring purposes to ICU. Right? Okay. You want to tell the last part, which is the take-home message.
So coming to take-home message, basically what we want you people to know because of this scenario. First is identify the women who are at risk for postpartum hemorrhage. Okay, and then be prepared for category 1 cesarean section. Okay, always directly go for J. What during my PGDS what we were taught is, if the obstetrician is inside the OT before an anesthetist is, go for J. Otherwise, usually obstetrician do not usually come inside the OTs. Okay, then ask for the required.
Platelet is alright. Can I go for a spinal? Because I have done it. Very I have done it. I have given a spinal.
I would still feel it is better to go with the general anesthetic because chances of it getting failed, like we cannot be so confident that within a single shot would get or something like those type of tricks.
I've been practicing for 27 years, I have not failed.
If I could add on to that, ma'am, I understand that you're in a peripheral setup and that is a real possibility.
And I'm alone.
Yes. So you might prefer to do that. But rapid
platelet count and the coagulation parameter.
Yes, but we have to remember this patient had an antepartum hemorrhage as well. So on top of that, not just the preeclampsia, is she in DIC? Because abruption is related to DIC. So we don't, if platelets are alright, PT can still be deranged. So that's something we need to keep in mind. If you're absolutely sure there are no problems with coagulation and you do want to, there is a specific way to do rapid sequence spinal. So, for example, the steps are you have to have 2 anesthetists. The senior anesthetist has to be scrubbed in and ready while the other one takes a quick consent and pushes in the patient, places the wedge, keeps them sitting. It's a single swipe with chlorhexidine. It's not, betadine and spirit and all that. You don't even bother to wait for a local anesthetic. It's a single trick if it works well and good. And while all this is, and you don't even add an additive because you don't have time to drop all that. And while all this is going on, the other anesthetist is pre-oxygenating. Because if this doesn't work, you have to induce and intubate the patient. So all these steps is what constitutes a rapid sequence spinal. That is only if you're absolutely sure there's no coagulopathy. So if you can do all this, yes, but then you need another person. So if you're alone, again, it's a gamble, I would say.
Yeah. For all the postgraduates, please do what is safe for the patient.
Yes, safety first.
Safety is always first, because that risk-taking behavior or whatever comes, I think, with age. Okay, so first do what is safe. Okay, we all want you to be safe anesthetist first. Okay, yeah. We'll end up this scenario.
Just for that little boy. Just only one character. Who's the boy who asked category scenario? So one is always next time for your scenario, call an obstetrician. Because one thing you're going wrong. I'm sort of not, when you are working alone, you use practicality. In Manipal, you have the whole set of people and you use your books. So this is mild abruption. So there's less chance of, anybody can have DIC, right? But the fetal heart is there. Coagulation failures in grade
distress.
No, that is still mild. Coagulation, when there's IUD and uterine, there's more chance, you know what I mean, it's mild abruption, less chance of coagulopathy. But you have to deliver fast. This is only for that boy. Who's the boy who has category? So Dr. Ramkumar also doesn't know category cesarean, neither do I know. So I send this message to Dr. Ramkumar, so I just want to read it out to you. Okay? Category 1 is immediate threat to the life of a woman or fetus. So what I know is cord prolapse, that's threat to the fetus, right? Rupture uterus for the woman, abrupt show, and uterine hypertonus. Okay? It's absolute threat. You can't be in a hurry. Category 2 is maternal or fetal compromise. So though we were saying it's category 1 because that fetal heart can go away anytime, but just a bradycardia or something like that will be maternal or fetal compromise, but not immediately life-threatening. So that you can take some few minutes. Okay? Category 1 is immediate within 5 minutes, especially cord prolapse. Category 3, needing early delivery but no maternal or fetal compromise. Or, little early delivery, okay, maybe some, mild preeclampsia, but no compromise, okay. Category 4 is the lady wants it on that day. So at a time to suit the woman and the cesarean section. Because you asked, other we can go on discussing, but when a student asks a question, we have to give the answer.
There's one thing I want to add which you must never do as an anesthetist, which this team did. Can you please say what it was? Cut off the inhalational agent. You cannot do that just because your patient is hypotensive as an anesthetist. You cannot cause awareness. Okay, that is as good as causing harm, which is what you all have sworn not to do. Okay, so you cannot be cutting off. Yes, and it is a good thing that you looked at the inhalational agent under anesthesia, under GA. Remember that any MAC above 0.6 or 0.7 can cause uterine atonicity and increase the bleeding. So you might want to give what's the word I'm looking for, something like midazolam for amnesia, but you never ever cut off. If you're going to cut it off, you have to give an IV agent to make sure that...
Like what do you want to give? Itomidate,
Infusion you will need to give, right? Does that cause amnesia? You can give midazolam infusion, you can give, if your patient is stable, propofol infusion, you can give ketamine infusion, so many options are there. Start a bit of dexmedetomidine, so many options. If your patient is stable, yeah. Otherwise use ketamine, midazolam, something like that. So anything to add?
So we'll stop here, sir.
Sure.
Thank you.
Right, the rest, the last team can come forward. I think the polls present.
Right, you have a mic, so start introducing yourself.
I'm Manivan, first year PG, KMC Manipal.
Dr. Sandeep, final year resident, KMC Manipal. Sandeep, first year PG, KMC Manipal.
I'm Anuj, second year PG, KMC.
Okay, Adi Chunjunagari.
I'm Nisha, first year PG, KMC Manipal.
Okay, so we have 4 people from KMC Manipal, looks like, and one from Adi Chunjunagari. Right, so I think you seem to be the second most person. So we make you in charge of the case, okay? And you can take the outlet from Adi Chunjunagari to be your assistant. Okay, so you both are going to be at the head end. Okay. You being the senior most will be actually doing the taking the decision. So all of you please move over this side. Okay, and then we can have, I usually like to allot, so not working. Hello, yeah. So I usually like to allot one person to be in charge of watching the monitor. Okay, and maybe I think you can do that. So your job is just to watch the monitor, identify things when they're going out of hand and inform the rest of the team. Of course, that doesn't mean that you don't look at anything else. You can always give me your feedback wherever you think something is being missed. Okay, so you're in charge of the monitor. Let's have you in charge of the IV administration, and we'll have you as a runner, basically. Whatever else is required, okay, during the part of this management, you will help the team. Beyond that, we'll help you also. Okay, so you can just wait here. What's the? I don't have anything to watch on the screen. Give me the script, please. No, you just wait there. I'll tell you the scenario. Okay. Hello. Yeah. So this is going to be you're listening. Whole team is listening. It's going to be a 48-year-old or a 46-year-old farmer who's been having a history of swelling in the neck for the last 5 years. Okay. It's obviously a thyroid swelling. The size of the swelling is 12 centimeters from side to side, going from one sternocleidomastoid muscle to the other, right? And vertically, it's about 15 centimeters long, okay? And the lower limit of the thyroid swelling can be felt. You can feel that in the midline, suprasternal region, the trachea is in the midline. However, it appears as if the trachea is pushed to the left, and the tumor is more on the thyroid swelling is more on the right. So to repeat the findings till now, a 46-year-old weighing 70 kg, I didn't tell you that earlier, weighs 70 kg, otherwise fit farmer, no other medical illnesses, has had a long-standing thyroid swelling over the last 5 years, growing very slowly. Okay, 12 centimeters from side to side, more on the right, pushing the trachea to the left, 15 centimeters from top to bottom. You can feel the trachea in the midline. Okay. The patient also does not give any history of change in voice, any difficulty in swallowing, or any difficulty in breathing. But does say that once in a way, he always likes to sleep on the right lateral position. He prefers to sleep on the right lateral position. Because when he goes to sleep inadvertently in the supine position, he sometimes does get up. And he needs to change position. This much history I have told you. You can ask for anything more in the history, and we then go on to the investigations, okay? Yeah, anything that you want to, you can spend a little time, not more than a minute. Ask for more questions if you wish.
Any other comorbidities?
No comorbididities.
Any
okay.
allergic history? Any allergic history, sir?
No history of any allergies, okay? Aren't we giving them some mics? We've forgotten that, okay? Yeah, yes, I think the team leader, and they'll give you this collar mics, okay? And we have a hand mic as well, whatever. But when you actually start performing procedures, you need your hands off.
Airway details, sir.
Airway details, okay. What would you like to know? I've told you something. already.
Any
So there is a deviation to the left
Malampati
and suprasternal region, you can feel the trachea. What else do you want to know?
Malampati classification, mouth opening.
Good. Upper airway examination, Malampati classification, all that is good. No issues. Okay? Right. Head and neck movements, all of that is fine. Any questions from any other team members?
Smokers.
Not a smoker. Not a smoker.
History of daytime sleepiness.
No. No.
Observed.
He's a farmer. He works very hard in the fields. He's got a BMI of 24. Okay. Kilogram per meter square.
Thyroid profile?
Thyroid profile, you mean biochemically?
Yes.
Euthyroid.
Preoperative video directscopy.
VLScopy done, both vocal cords are moving. Okay? And you can see the vocal cords well. By the indirect laryngoscopy done by the ENT surgeon. Okay? Any other questions? You asked for some biochemical investigation. Would you like to do something more? Anybody?
Hemoglobin.
Yeah, okay. CBC normal. Let's try and keep it simple.
Electrolytes and ECG.
Normal.
Chest X-ray, epilateral wing.
Sorry?
Chest X-ray,
You're
epilateral.
throwing your voice behind me, so wondering. Okay. Chest
X-ray.
Chest X-ray. Yeah, oh, come up there. Okay.
Lateral.
So read the chest X-ray since you asked for it. Yeah.
There is a deviation of trachea to the left.
Okay. So it correlates with the clinical findings. Anything else that you notice?
Old displaced clavicle fracture.
Old?
Clavicle fracture.
What did he say?
Old displaced clavicle fracture.
I didn't say that. Okay, but we'll accept it. Okay, it's displaced and is it fixed? Any pain he's complaining of? Then no pain. Okay, so he had, okay, maybe he had a fall in the field. He had a fracture of the clavicle, it got fixed. Thanks for picking that up. Okay. Okay, I think we've had enough of a hurdle to find out. Any other investigation that will help you in the management?
Electrolytes.
No, forget biochemical. Let's stick to, now we're talking about radiology. Any
CT.
other film that will help you?
CT like
CT. Okay, we have a CT. And Tara will play the CT for us, so you can observe what's happening. Various cuts will come up in fairly rapid fashion. Okay. So now we're entering, you can see the deviation to the left, right? Coming back to the midline, there's a manubrium sternum going by, there's the mediastinal shadows and the carina. Okay? So essentially there is no retrosternal extension. How else can you find that out, retrosternal extension? And lateral film of the neck, did you say that?
Yes,
you didn't say that, okay. I was hearing. What did you say anyway?
Examination we could get under this one.
Examination?
We already could get under this one.
Okay, fine. So no retrosternal extension. However, what else can a lateral X-ray tell you? Can you tell you whether there's any anterior-posterior compression? Now, since this we are concentrating on the airway of the patient, you do need to know, okay, one, is there any anterior-posterior compression? Is there any deviation? And from the CT, what other information would you like? Last thing before you go on to manage this patient. Does it help you in deciding what kind of a tube you're going to use and what size of tube you're going to use?
Yes.
What kind of tube I said first and what size? Okay, so you can measure the tracheal diameter. So from there you can decide what size tube to use. What kind of tube are you likely to use in these patients? A flexometallic tube because there is a deviation, right? So all this information is there, and if there's nothing else that you would like to have, we can go on to manage the patient. If you can make a team decision what you're going to do, you can take 30 seconds, 1 minute and tell us what you're going to do. And then remember, as earlier we have told, you're going to start anesthetizing the patient and you want the monitors on, you need to tell us what you want on. Okay?
I want
and one moment please. Rest of you please watch what's happening. You're also part of the team, okay? And we're going to observe what they're doing, right? And at the end, we're going to sit down as we did earlier and find out what they did right. And if you would have done anything different, right? So that we get a complete learning experience from this. Because being there in the hot seat is pretty difficult. Sometimes you don't take decisions that are expected of you, okay? But sitting there cool, you know, you're watching the scenario and you can talk to your neighbor and discuss, no, this is right, this is wrong. You know, that's all much easier, right? So you're all actively participating in this scenario. Because you're the team leader, you're the assistant team leader, you're in charge of the IV, right? Monitor, and you're the runner, so please come here. Runner essentially is going to hand over things from this tray as the team is asking for it. If you don't find anything, just let me know, I'll give it to you. Okay? But you can stay close to the action, no problem. You don't have to stay close to the tray. Go ahead. You have a plan in mind? Go ahead.
First, we would like to keep the OT ready, sir. Check for ambu bag and working laryngoscopes and inhalation agents, sevoflurane and isoflurane as well. And I want the oropharyngeal airway and nasal airways and fleximatic tube size 8, 7.5 and 7 and IGEL size 4. What's the weight of the patient?
70 kilos. 46-year-old, 70 kilos.
Check the tube and I want stilet, bougie ready and emergency drugs, scoling to be loaded.
You can open. So is that size appropriate, you think? Unfortunately, that's the only size we have here, so we consider it's appropriate, okay?
Stilet to be inside, airport. Bougie is ready and
so knowing that it's an airway related issue, you're checking all the airway related stuff. Okay? Once you're happy with it, you can go ahead and start your anesthetic.
I also want to inform the surgeons about emergency tracheostomy if required.
Well, the trachea is not really felt except to the immediate suprasternal region, but anyway, you can tell them. Okay, an experienced surgeon is going to arrive.
Yes, and so our plan A will be inhalation induction and plan
Mine
B.
doesn't seem to be picking up. Will you hold it in your hand to start the action? Yeah.
Plan A can be inhalational induction and I want one person to hold the thyroid and the plan B can be a big fiber optic and yeah, we'll
So since it's an A, B, why don't we go to C as well? No plan C. Do I take it that there's no plan C?
Emergency tracheostomy.
Okay, the surgeon has been told about that. So your first choice is going to be, what does the team feel? The team leader suggests something, what do you want to go with?
Is the plan okay?
Go ahead. Go ahead. Your plan A was an inhalation induction. Okay.
So because the patient sometimes feels breathlessness and supine position, I want some head up.
Yeah, okay, we'll have to presume that. I think we can't do that. You're right, Tara? Tara, we can't, I don't think we can do that. It's a flat body, unfortunately. So we'll presume that you've done the head up. Okay, I'm sorry.
NPO adequate?
Good idea, but we can't do it, yeah.
NPO is adequate?
NPO is adequate.
Okay,
6 hours for solids, yeah.
Working IV line, check for working IV line.
IV line started. And
I would like to introduce myself to the patient as well, sir. And connect the standard monitors, ECG, and okay.
No whispering.
It's a difficult area, so we have to take a high risk.
Okay.
And ICU bed
So
also.
you want to take the high risk consent, okay? Fine, yeah.
And ICU bed, there's like
ICU bed available, Priyanka?
Yes.
Okay.
Attach the monitors, please. ECG, blood pressure, and saturation. Let's note down the baseline vitals. I would like you to pre-oxygenate the patient.
You have to use this the resuscitation bag, okay? We don't have an anesthesia machine as we told you earlier. Would you also like to tell your patient something?
So we will be holding the neck and lifting the thyroid.
Yeah, there you go.
You can just take long deep breaths. You don't have to be scared. You give some drugs to the IV line and you will fall asleep, so you don't have to be scared.
What's wrong? Just hang on for a second. No, display on the monitor is not the same. Now it's going to change, I think, okay? Why is the display coming like this? Okay. I'm sorry, please don't go by the pleth or the ECG. That's misleading. Go by the numbers. It's some technical issue. So we have a heart rate of 79 and a saturation of 98. Okay. The pleth is showing much faster and it's coinciding with the ECG. Okay. Some technical issue. Right. And the blood pressure is 120 by 80. you have all the necessary details and we have you pre-oxygenating the patient.
Yes, pre-oxygenating and so you can give some fentanyl, 50 miles.
70 kilos. Okay.
200 per kg. And can you please turn on the fluorine 8% on the dial?
Sevoflurane 8% being turned on. And fentanyl has been given, is it?
It was 50 mics.
Okay, 50 microgram of fentanyl has been given. Just the nod to the registration.
I'm lifting the thyroid with my hand.
Okay.
Are you able to, is there a chest raise? Are you able to ventilate?
Tachycardia.
I think, should we just go into the elevation?
Oxygen 100%.
Oxygen is 100%. Oxygen is 100%.
Following induction to the sevoflurane at 8%, you find that the saturation has dropped to 89%.
Oxygen 100%.
Oxygen 100%, is going. Oxygen along with sevoflurane 8% is going. Blood pressure 120 by 80, but the saturation dropped to 89. You have pulled up the gland, but you started hearing a sound like this.
Please auscultate.
Yeah, can we we'll keep an oral airway. What can you hear?
Crips, bilateral. Crips are.
So the team, one team member is pulling up the thyroid gland. What else have you done?
We have put airway.
You're still going, you're putting an oropharyngeal airway. No change, okay?
Still the crepitations are there. Some dexamethasone and
I'm in charge of monitor, please read out the values so everybody is done. Go by the numbers only, please.
28. Saturation at
We are getting very slow, so we are able to ventilate. Can we give some dexamethasone and hydrocot as well?
Please remember this sound is continuing. I can't do it for too long.
Good dexamethasone and hydrocarbons were given at a dose of 100 ml.
capnograph seems like this is bronchoscopy.
Yeah, can we give some salbutamol first? And also some positive pressure.
Saturation dropping further, 74%. BP has shot up to 180 by 100.
Can you give some Esmolol? 0.5 mg per kg.
Just to recount, we're still on oxygen and sevoflurane 8%.
Okay, can we reduce the inhalation?
And
give some
given Esmolol, how much are you giving?
0.5 mg per kg I have given, sir.
We will find out.
We will give some IV propofol.
Saturation still at 78. Okay, we have lost the capnograph, right?
Good observation.
We lost the
capnograph. And as I said, I'm not making that noise anymore. Sorry, I can't do it for long. That noise I hear.
I think we should intubate.
Yeah, can we just paralyze with scoline 0.1 mg per kg? 1 to 2 mg per kg.
Scoline 100 mg given.
Scoline 100 milligrams being given. It's about
Saturation dropping.
Can we change the airway, give some airway maneuvers, please?
Can you be a little more specific to the team?
Last one's head in left.
Succinyl choline fasciculations have appeared.
Okay, can we
and it's almost disappearing now. For a minute after succinyl.
Can we go ahead with intubation? Are you able to visualize? Check for
tube is in. Let's see what's happening.
Okay, ventilate please.
Heart rate at 55.
Can you auscultate? Give atropine. Give atropine 1 mg.
Atropine 1 mg given.
Can we take another BP reading?
Would like to point out that there is no capnograph.
Still doing at our ETC advertise.
What about the auscultation? NNT is equal.
Equal bilateral RSC is equal.
Saturation is at 81%.
The team members has checked the air entry. Says it is equal, but there is no capnograph.
It's coming, it's coming.
RNT is there and equal.
Any added sounds are there?
Yeah, bilateral cribs are still there.
Have they given salbutamol?
May I request another team member to also check the air entry, please?
Saturation
Is this the latest BP value, sir? Blood pressure value?
Blood pressure, you want to recheck? Yes, please. We'll give it to you.
It's more on the right.
Okay, can you just reposition the tube, please?
Air entry is there?
More on the right.
Added sounds.
Okay, I am told that the air entry is there, but more on the right.
What added sounds? This is the latest BP reading, sir.
Okay, so I believe, yeah. No, it's not yet come on. We're still checking.
Capnograph still looks like there's bronchospasm. Saturation is improved.
Okay, 2 people have auscultated. Do you find response equally on both sides? Then we'll accept it. One side less.
Right side.
Right side is less. Okay. Tell that to the team. Let them take a decision.
Tube has been readjusted.
Equal on both sides. Can you just check once? If okay, then we'll paralyze the patient with vecuronium.
Saturation is now 95%.
Okay.
We still don't have a good
Vecuronium given,
capnograph
right?
response.
Paralyzing. Vecuronium
Vecuronium IV given. Capnograph still persisting. It's coming. Okay, and we still have bilateral air entry. You adjusted the tube?
Yes.
Okay, fine. Thank you. We'll call up the scenario now. Okay, great job. Please give a hand to the team. Come forward here so that we can see how the scenario went. Okay. So the history was clear, right? Thyroid swelling. Okay, and then you said you have 2 options in mind. Can you explain once again why you thought of those 2 options?
Sir, because there is an anticipated difficult airway.
Okay.
And so I wanted to plan ahead. What is the plan of action so everybody is clear about it. And
Okay. Would you like to add anything? No. So in anticipated difficult airway, did you anticipate the difficulty in passing a tube into the intraglottic region or actually visualizing the larynx? What did you anticipate? Did you anticipate, in simple words, a supraglottic or an infraglottic problem?
an
Say whatever it is. When you look at him, he said he's got nothing else to say.
visualizing the block is I was expecting a difficulty in intubation.
You were expecting a difficulty in. Hold the mic. I'll take it back from you. Speak into the mic.
Expecting both difficult mass ventilation and intubation.
Okay, right. So 2-3 terms have been introduced. I think it's a good time to clarify that. Difficult mass ventilation can happen because of supraglottic problem or infraglottic problem. Agreed or not? Right. Now this problem is being caused by the thyroid. So primarily it's going to be an infraglottic issue, right? It's an infraglottic issue. Okay? And you had decided that, so one is difficult mass ventilation. So difficult laryngoscopy may not be a problem. Okay, because the entire problem is over the trachea itself. Entire problem is over the trachea itself. Right? There's something called a compromised airway. What is a compromised airway? Anyone? For the audience also? Any one of you? Compromised airway, would you like to talk about that? Because I think that's where we're getting at. This is a compromised airway. It's not, may not have been a difficult intubation in the sense visualization of larynx may not have been difficult, but there is an intraglottic problem, right? So you had chosen one technique, and you had also given an alternative technique. I would like to know why the team decided on the plan that you chose. Was there anybody who tilted the balance, or did the team leaders themselves decide? I would like to know why one was chosen over the other. What is the other option given? Awake fiber optic intubation, right? So these are the only two options available, and they chose to go with an inhalation induction. Okay? Not wrong. Okay. But did we land up with some trouble? So in hindsight, we now realize that maybe that option that we chose did land us in some kind of an airway related issue. That is the definition of a compromised airway. It's an airway that you expect to have a problem, not supraglottic, but infraglottic, and you need to be prepared for that. Right. Now in that context, we talk about why your second option, would it have been better or worse? The three are quiet. Pick up the mic, you have a mic with you. Did any of the team members think that an awake fiber optic guided intubation would have been better? Among the five of you, how many of you would have preferred that? Just the five of you. Raise it high. No, now you, okay. So in hindsight, you are okay. So essentially, I think our bad experience has now pushed us into the right direction, right? But I was very happy when I heard the other option. How many really in the audience, there are about 8 or 10 people here who can give the award, how many would have gone for an awake fiber optic guided intubation, given this system? And you've seen the CT findings, okay? Just one, two of you. So the rest of you, what would you have done? What they did? Okay. Can somebody tell me about inherent safety of awake fiber optic guided intubation? I'll leave you quiet alone for some time. Let me concentrate on that. Yep. Would you like to tell us why an awake fiber? Two of you raised your hands. You raised your hand very hesitantly. So let me give you the mic also very hesitantly. Tell us why you think an awake fiber optic guided intubation might have been a better choice.
So, because after we had reduced the patient, the patient had lost the control
I think you are not heard to some reason. Can you take a little closer? Take a mic a little closer. Yeah, I feel loud.
okay. So while we have reduced the patient, now.
Hello? Give it a better mic.
Hello?
Yeah. Mic.
While we have induced the patient already, now he has no control over his airway, and also the mass is so big that that's why you earlier only said that the mass is huge. So while we induce the patient, he has lost his control, and also the mass is so big, and the patient is in such a position that the mass will compress the airway. So going ahead with the fiber optic, I think that's a better choice, so that even if there's any difficulty, the patient is able to keep his airway.
Okay, let me take you to another fault in the algorithm. Fiber optic intubation is an acceptable option. Awake or asleep. Awake or asleep. You see your patient is very anxious. Doesn't want to be awake. Wants to be put to sleep. That's what then we would have done something like this, right? So is it worthwhile convincing your patient then that an awake is better for his life is concerned? Awake, I think you only know 2 people agreed and 4 of the 5 panelists there agreed that awake fiber optic was a better option. For some unknown reason, you went for the second option. And then we realized that it was a mistake, right? This happens, okay, very often in clinical practice also it happens, okay? So, what is the final take-home message at this point of time? Do something with your patient where you don't lose control of the airway. Now, the team did try an Goodell's airway, right? An oropharyngeal airway was tried. Did it help? Why did it not help? Because it's an infraglottic problem. For the same reasoning, would a supraglottic airway device have helped? Like a iGel or LME or anything like that. Okay, so remember very clearly, when you think of any reason of airway obstruction, try to classify in your mind what is supraglottic, likely to be supraglottic, and what is likely to be infraglottic. Now the ENT surgeon has done an endoscopic examination, and did they find anything wrong? We said that up to the vocal cords they have seen. Right, so we presume that any airway obstruction that we're going to land up with is likely to be an imperfect cause. And keeping that in mind, I think we have to plan our anesthetic. It's okay. So, though you are the only one not convinced among the team, and even among your audience, there doesn't seem to be much support for a awake fiber optic guided intubation. But I think that is, you want to say something? You're looking very eager to say something. Yes,
If we had chosen awake fiber optic in this simulation, what would have gone wrong?
Nothing would have gone wrong. Thank you for asking that question. If you had chosen awake fiber optic guided intubation, you would have been headed home by now. Okay? Because the surgery would have been over. Right? So I think you took the wrong turn. Right? Thank you for asking that question. Okay. So that's a choice you should have taken. If it makes your heart beat any lighter, the morning team also didn't choose that. Okay. And they chose something worse than you. They chose something worse than you.
He answered correctly.
Huh?
That boy answered correctly.
He led us back to the track.
No, so what I told you yesterday, no, you need not do that.
I know, he has applied a little gel today, but he's not cut his hair.
I told him to cut his hair, cut his beard, because you answered right, you need not cut it.
Your excuse, okay. So I think the team has now led us back to the fact that I think they are agreeing that they made a wrong decision. Thank you for agreeing for that, okay. And how did we realize that? Only when we started having right? Now could you have had this happened with an intravenous induction with fentanyl, propofol and a muscle relaxant? Would it have happened? So thankfully you didn't choose the worst option. Right, so I'm very happy that you chose one of the two better options. Okay. Now tell me one thing. Okay. Awake fiber optic, hopefully we'll all agree now, that is the best technique. Okay. If you're not convinced, I'll say that again 10 times more. So let that be one take-home message. In such a situation, please consider that an awake fiber optic intubation would be the best choice, especially especially if you are less experienced. Okay. When you are less experienced, you take less risk with your patient. When you are more experienced, you know you've had 20 years history behind you, you've seen 20 such patients, and you know what's happened to those 20 patients. So you might take a little different choice. Agree, madam? Right, okay. So I think intravenous induction would have been the worst option. Okay. So now, suppose I had one last question before I send you back to the audience. Okay. Suppose I told you there's a retrosternal extension. I know you very meticulously checked the difficult airway cart. Okay. Should I feed this question to the audience or to you? I'll give it to you. You're sitting very politely. Okay. What other equipment do you think would have been essential? I'll just phrase my question very carefully. If there was a retrosternal extension, as evidenced by a CT scan and by a lateral neck X-ray, okay, and the patient does have a kind of stridor at rest, what other additional airway equipment would you think would have been necessary in the difficult airway cart? If you want to say pass, we'll ask the audience. Anybody from here? This answer is given, maybe H.M. Krishna may say this is age old. You don't think of it anymore, but it's not age old. Okay, has anybody wants to give an answer from here? No. Has anybody heard of a rigid bronchoscope? Have you seen cardiothoracic surgeons do a bronchoscopy? Nowadays they also do fiber optic bronchoscopy. But a rigid bronchoscope still has a place in the difficult airway cart. You check any book that talks about difficult airway cart. When there's a retrosternal extension, none of the things that we can do, even the surgeon, most experienced surgeon that you ask to stand by, can do anything in that case. You have to get past the obstruction, and you can only do that if you have a rigid fiber optic scope. Okay. Now, there's a point that we all missed in the pre-operative investigation. We stuck to radiology, right? X-ray neck, anteroposterior, lateral. We talked about the CT scan. Is there anything else that we could have done? There are 2 workshops going on that today. Ultrasound, okay? Ultrasound evaluation of the airway. Since you mentioned that, can you tell us what extra information you can get from that, if you would like to tell us? So the right answer is ultrasound, okay? And our colleague here is going to tell us why or what extra information is going to be. Hold it. I'm not going to hold it for you. Come on. Please don't feel threatened anyway. If you don't want to answer, but your answer is right. Okay, an ultrasound evaluation is very important. Anybody? In what way is an ultrasound evaluation better than a static X-ray of the neck? I've given you the answer there. What's the opposite of static?
So she wants to answer something.
Who wants to answer? She wants to answer.
No, sir, I was just going to say it's dynamic because you said static.
Oh, that's all. No, it doesn't matter. Now you'll explain why it's dynamic. You committed yourself. Okay. See, we good examiners will give you nice clues. They don't come to fail you, right? Hold it closer, speak louder.
It's a real-time examination. The patient is
Very good. It's a real-time examination. Okay.
CT scan would just show us cuts, sectional cuts.
Okay. It's at one particular point of time. Therefore, I'm using this as a mic. Okay. So give me another mic if you have one. Okay. So it's a real time. It also gives you what happens. The CT may be done at start of inspiration, mid inspiration, okay, end of inspiration, start of expiration, any point. They don't coincide that, right? Whereas with an ultrasound, you can actually study the entire cycle. Not just one cycle, inspiratory, expiratory, inspiratory. You can study as many cycles as you want, but only as far as the ultrasound probe will go, right? Now, suppose there's a huge retrosternal goiter. What other tests can be done? As a build-up on a CT or an MRI. Has anybody heard of a 3D reconstruction? You're shaking your head. What is a 3D reconstruction?
We do with the CT scan. We do with the CT scan, post which like we try to break the full 3D description of the whole area to see the exact size of the human.
Absolutely. Okay, it's like saying I want to go from here to Bangalore. Earlier I just got to the bus stand and got into a bus. The driver will take me to Bangalore. Now I want to know which route I am going by. So I start looking at my GPS. Is he taking the shortest route? Is he taking the best route? And so on and so forth. So what you are describing is now just a simple app, okay? Radiologists using this app, they do a CT or an MRI, and from there they give you a virtual image of the tracheobronchial tree. So you know exactly at what point it is narrowed, which direction it is taking, and so on and so forth. So you can actually have a real-time plan of what is happening. So that's one investigation that we missed out till now. So to complete the investigations, a plain X-ray of the neck, AP lateral, okay, a CT scan or an MRI, a build-up on that, a 3D imaging of that, and an ultrasound is what will really complete an evaluation of the airway. Okay. Now I think I'll ask you to come back here. Okay. And we'll just try to wind up now. Last 5 minutes. So what I'm going to do now is, with all this has happened, we've seen at least 3 techniques that have come up in our minds. Okay. One technique was a conventional intravenous induction. Using whatever, propofol, thiopentine, ritonavir, any muscle relaxant, you choose. Okay. A narcotic agent, an intravenous anesthetic agent, and a muscle relaxant. Any combination is one technique. Right. The other technique is a sleep or an awake fiber optic guided intubation. In between, you have a situation which is what this team chose. This team chose to do an inhalation induction, and then they continued with an inhalation induction, and they finally managed the day. Okay, but not without a few tense moments, right? There were a lot of tense moments there. So now let's see, as a take-home message, how we should start planning for a thyroid swelling. Okay, not so fast. Priya wants to go home, I think. Huh? Right. You just went fast forward. Okay, so these are all the things. The pre-anesthetic evaluation, I gave you an option to ask me whatever questions you wanted to. Clinical examination, we really could not create a thyroid swelling for you there. But in real life, you'll have a thyroid swelling. And this, I think, I don't know when I told this morning or afternoon, I think they're all postgraduates. You'll be reporting to your consultants. Okay, and if there is a doubt, sit in the ward, ask your consultant to come to the ward. And don't leave the ward till they come to the ward. Okay, because there's nothing like evaluating an airway by an experienced person, and that experienced person will tell you what you have missed and what you have not missed. Okay, don't rely on just photographs and videographs and things like that. Okay, because the best time for the team to examine the airway is the evening before surgery, so that you can plan overnight what you're going to do. Right? So make sure that you will call your consultant to the ward and tell them, please, ma'am, sir, I'm not very happy. I would like you to see this. And I'm sure they'll come. Okay, right. Additionally, I just told you the relative advantages and disadvantages of these things. Okay, management plan is created. We're going to talk about the 3 plans now. Airway equipment, all of you checked, and I just added one equipment, which is the rigid bronchoscope, which is absolutely mandatory when you have an invasion into the mediastinum. Okay, and there's a retrosternal extension. The further it extends, the closer it goes to the carina, the worse it is. Okay, and you can have thyroid, small thyroid, little bit of retrosternal extension. The surgeon will say, oh, I will scoop it out. And he will, right? But there are some where they have to do a sternotomy. So your surgery becomes more complicated, and so does your anesthetic. Okay? Difficult airway card, I think we checked it very well. I got everything being voiced very well. And I just added this point about the rigid bronchus. Next slide, please. So here you have a nice, like a traffic signal, green, yellow, and red. Obviously, green. In India, we start, red we start moving, yellow we start moving faster, and green we really move as fast as possible. Okay, that's what we do when we see a traffic light like this. But jokes apart, green really tells us that you can go ahead. And what does the green end of the spectrum say? No difficulty anticipated. Does our patient fit into that? Can you boldly say there's no difficulty anticipated? Therefore, we ruled out the possibility of an intravenous induction. Whatever combination drugs you would use is ruled out. Okay. And the dictum is, do not burn your bridges before you cross it. Okay. Come to the extreme right. I told you what's a compromised airway, and we dealt with a compromised airway. Okay. It may not be a difficult laryngoscopy. It may be a difficult intubation because the airway in the subglottic region is compromised. And this is going to give us trouble sometime. Did I give you a hint in the preoperative history? Did I say that the patient preferred to lie on one particular side? And then one of the team members also lifted the thyroid. So all of you were aware that there was a positional variation. The ultrasound would have given us a better idea. Okay? Right. So you have at the other end a compromised airway, and that I think the appropriate choice would have been an awake fiber optic guided intubation. So one extreme, intravenous induction, any complex drugs that you want. I don't have any doubt about the airway. I go ahead like any other conventional induction. Now this may be a small thyroid, 2 centimeters by 3 centimeters. You can feel the entire trachea. That's my phone, no? It's 40 minutes, yeah. Last 5 minutes I finish up. Okay. Right. So what was I saying? So you know that if you have that kind of a thyroid, small thyroid, no compromise, you can practically feel the entire trachea all the way down. A surgeon can also intervene if there's a problem and do a tracheostomy, no problem. Go for an intravenous induction. Right? Extreme right? Awake fiber optic guided intubation. If your patient is really very, very scared and you are willing to take that risk, you can do exactly what they did. But you start landing up with, please cut off all agents and get back on your plan, awaken the patient. Okay, that's the point I hope you would back off. And your plan was still okay, but you didn't back off. Right? And that is what made your plan wrong. In between is where, so no problem anticipated, conventional live induction. Next please, clear. Never compromised, awake fibroscope, guided intubation. In between, many of us sit on the wall, right? You don't know which way to go, right? So this kind of decision will be there in every clinical situation. We don't have clear-cut answers to everything not only in anesthesia but in medicine, right? So if there are clear-cut answers, you can take one or the other decision, left side of the spectrum or right side of the spectrum. In between is when you will do the inhalation induction that you do. So I would broadly describe the management of this patient as Plan A, intravenous induction, Plan B, inhalation induction, Plan C, awake intubation. Awake versus asleep depending on the condition of your patient. Okay. So you took the right decision to do either middle or right. You started off with the relatively wrong decision, but you didn't back off at the right time. That's what I feel. Okay. So that's how I can summarize your performance on this particular case. Right. Go on. So I wanted to talk about what's called a cuff leak test. Has anybody heard of a cuff leak test? This comes in the extubation strategies. I know we're all tired. I'm not going to talk about that, though it will take another 8 to 10 minutes to talk about that. But I'll just give you a reference if you can note it down. Indian Journal of Anesthesia, 2016 year, volume 16. Indian Journal of Anesthesia, volume 60, 2016. Okay, there's a series of 5 articles brought out by an association called the All India Difficult Airway Association. I happen to be associated with that association. Okay, and as a chairman of a guidelines committee, we brought out, as the chairman of the committee, we brought out 5 guidelines. Please do take some time to read it. One of the guidelines is about extubation, and this cuff leak test is explained in detail. Okay, so various scenarios there. You have an obstetrics scenario, a pediatric scenario, ICU scenario, an adult and unanticipated difficult intubation, and extubation strategies. Not because we were one of the authors. It's a document written for the Indian context. And we're all going to practice in India till you pass your examination. After you will go to UK, Germany, wherever it is, I don't know, right? But till you're in India, I think these algorithms will help you because they are written specifically with the Indian context in mind. So with that, I think I will end. Thank you so much. I hope you have enjoyed and learned something today, right? And of course, it's about an hour later than what we anticipated. But I allowed people to leave because I didn't want to miss their classes. So we just have a little bit of a valedictory. Yeah.
So this workshop would not have been possible without the help and support of a number of people, and it is only right that we thank them because they put in a lot of time, a lot of effort, a lot of thought, a lot of input into all of it. And so I'd like to felicitate a few people, starting with our own Dr. Ram Kumar, who has been invaluable. And I say that you have no idea what I mean, because sir has been a tower of strength and support to us. And anytime we needed any kind of clarification, he was there, very involved and active, and he's come in to give us a support through our whole planning process. So I just want to say thank you once again.
Thank you. Thank you for calling me back to this center that we set up in 2008. I'm always happy to be back. And thank you. And it's a friendship flower. My wife was there when she was born. So I've carried her as a 3-year-old child.
And Ram Kumar sir is never far away from Vani ma'am and vice versa. So we'd like to felicitate ma'am as well. Thank you ma'am for being a part of our workshop and taking an active interest and being a part of it and livening it up in ways that we could never have done. Thank you. And we hope you'll come back.
So I think after that scenario, obstetrics scenario, in lighter vein, okay, in lighter vein it's not part of any textbook. We have to introduce a new category of cesarean section. 1, 2, 3, 4 we already learned, but category 0, which also includes obstetric distress. But she's never distressed, okay, I'm just telling you openly. She just played it because Priyanka told her to do it.
So we are all anesthetists.
But category 0 doesn't exist.
We are all anesthetists and we are not used to trauma, dealing with fresh trauma, unlike Dr. Prithvi, who has come from the emergency department to be a part of it, and we thank you, Prithvi, for really taking the effort and being a part of it. Thank you. I request Dr. Ram Kumar.
I retired for some time and I'm so glad that I was part of the simulation with you because I've heard so much about the way you teach and you stood up to your reputation. Thank you so much.
Without this simulation lab, we could not have done anything, and so I want to. These are the people who work behind the scenes and are an integral part of it. And Soumya is not here with us. This is Dina. So I request you to take them as well. I came prepared with a whole lot of lists of your attendance sheets and all, only to find it already printed it out, and kept it ready. So that's the way they work. Before we need it, we ask for it, it's already there. And
she's a great mimic of a neonatal cry.
And of course, without our simulator, we cannot be doing the simulation workshop. These are the guys who allow us to practice on a mannequin so that we can be safe with our patients. And so I'd like to thank the Ladal team. Can I have Mr. Resham?
The guy I wanted to marry. Last scenario I did like an old woman and that boy got so scared. So I thought you can't see my grey hair.
You're asking the husband to give the...
No, I want him to
You want to marry him?
No. He'll marry somebody else.
Get married again.
Mansa.
Thanks so much. They work very hard.
Yeah, they really work hard without food and drink. In spite of us telling them, they were working for close to 12 hours after an overnight journey. Yeah. And Mr. Dinesh. The only reason all of this came together was because the AV team came in at the last moment and provided us the support that we needed. So I want to thank Mr. Jagadish, sir.
In fact, Jagdish was literally a 11th hour decision.
Yes.
Thank you for coming.
Yes,
here.
yes.
Thank you.
We couldn't
All
have
this
done
is
it.
possible only because you agreed to come. Thank you.
Thank you. So, and most of all, thank you for your active participation. Simulation is highly dependent on the delegates who come. We hope it has been beneficial for you, that you've learned something from it, and that you will take away messages from this and use it in your practice as well. Does anybody have anything to say? Otherwise, I'll ask Dr. Ramkumar to close.
Anyway, okay. I just want to say that, there's a lot of lessons that even I have learned from morning to evening, okay? And I'm sure you would have learned as many, for sure. So the idea is to translate all of this into your practice, essentially. And what I would say is that obviously you can't go to a simulation center every time. So they always say that, in a simulation center you can kill the patient and get the patient back to life immediately, right? Which is not possible in real life, okay? But what I always used to say when I was working in Manipal, and when we have a difficult case, I used to say, okay, now everything has gone well. Suppose this had happened, what would you have done? Right? You can always discuss what are the other things that could have gone wrong in any patient that you manage. Maybe you made the best plan possible, you were on your best behavior that day, your consultant was really good, and nothing really happened bad. But there's no harm in thinking what could have been possible if things had not gone so smoothly. And those are the things we're trying to demonstrate here. Okay. In real life, as Vani was saying, things don't go so fast. You do get some time to decide. Okay, here we have to finish the scenario in 8 to 10 minutes so that we get the maximum possible information across to you. And that sometimes is a little, not very clinical, right? But simulation is just one way of learning, and I hope that you can translate this into your own practice. And most importantly, I think most of you are postgraduates here, sitting here, except Madam, I think. And I would like you to badger your consultants with questions. Okay, don't let them go that easy, right? All of them standing here, they're all very knowledgeable. I learned a lot from them, interacting with them. And I think it's your mistake if you let them go easy, right? Talk to your consultants, ask them, what should I have done, madam or sir, if this went wrong this way? Okay, and that's the only way you can take yourself forward. Okay, and my last comment is that you don't have to make all the mistakes in the world that are described as complications in anesthesia textbooks to learn how to manage a situation right. Okay, you cannot. Even if I live for 150 years, I'm simply making mistakes, right? Because the subject is such. So learn from other people's mistakes, right? And how do you learn from other people's mistakes? Not by criticizing them, but sitting down with them and having an academic discussion. And then you know that, okay, in X's hand this happened, it should not happen in my hands in future. That's the only way we go forward in any clinical subject. With that, all the best to all of you. Yeah, thank you so much. Yeah.